We are live.
Yes.
Good afternoon, madam. Now we shall start live. I am Dr. Meena Mahalingam, coordinating the session for day 1 ICOG certificate course on Urogynaecology. Would like to welcome our president, Sunita Tandilwakar, madam. And now I hand over the session to our convener, Dr. Kavita Banwal, madam, who is the chairperson of the Urogynaec committee. Over to madam to take over the session.
Thank you, Dr. Meena, for your kind words and for introducing yourself as well as me. Namaskar and good evening to all and one.
Madam, your voice is little low, madam. Kavita, ma'am.
Okay. Let me increase the sound.
अभी तो ठीक था.
Yeah. Okay, now is it clear?
Yes, ma'am. Can you come a little bit closer to the mic, madam?
Yeah.
Okay. Yeah. Is it okay?
Yeah,
Yes,
better.
madam. Yes.
Okay. Namaskar and good evening to all and one. From today, we are having 3 days Foxy ICOG certificate course on urogynecology and pelvic floor surgery. Urogynecology, also known as female pelvic medicine, is a subspecialty of gynecology focusing on women's pelvic floor disorders. I, Dr. Kavita Banwal, Chairperson Urogynaec Committee, welcome President Foxy, Dr. Sunita Tandilwakar Madam, ICOG Chairperson Dr. Parag Viniwala Sir, Secretary General Dr. Shuvarna Khadilkar Madam, Chairperson-elect ICOG Dr. Sheila Mane Madam, Vice Chairperson ICOG Professor Ashok Kumar Sir, Secretary ICOG Sarita Bhalera Madam, all the eminent speakers, brilliant chairpersons, conveners, Dr. Suman Sinha Madam and Dr. J.B. Sarma Sir, and all the 3 vibrant coordinators, Dr. Meena Mahalingam, Dr. Sandeep Nikhade, Dr. Mukta Agrawal. I welcome all the delegates who are going to participate for 3 days CME. This CME has been awarded 10 ICOG credit points. I request the participants to listen carefully all the topics so that they can fulfill the test. On first day, anatomy of the pelvis, perineum, pelvic floor disorders, transperineal ultrasonography, principles of pelvic floor surgery, POPQ, practical application and limitations, surgical management of POP in childbearing age, and steps to be taken to prevent valve prolapse, as well as selection of pessaries, surgical management of interior compartment defects will be dealt by our eminent national as well as international speakers. So I welcome all of you for this important and brilliant CME. So we start any event with the blessings of God. Today is the birth anniversary of Lord Vishwakarma. Let us join hands in lamp lighting, which symbolizes removal of all negative things and spread of knowledge and wisdom. So please start lamp lighting.
Kurutvam kalyanam arogyam dhanasampadah shubham kurutvam kalyanam आरोग्यं धनसम्पदः शत्रुबुद्धि विनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. So now it's time to get blessings for our office bearers. So please display CV of Dr. Sunita Tandilwakar Madam. Though she needs no introduction, and I feel greatly honored to introduce.
You have given only 10 minutes for
Madam,
this.
our visionary and dynamic, elegant President Foxy Sunita Tandilwakar Madam, who has pearls of wisdom. I must congratulate for having so many laurels to her credit. She has been awarded just
Kavita,
last week. Yeah,
you have only 10 minutes. It's academic session.
Okay.
And we are already 4 minutes
Okay, madam.
past.
So with your permission, I request you to bless this CME.
Thank you.
Thank you so much.
Thank you all the conveners for reminding me again and again. Thank you so much for that. ICOG, these 3 days courses on various subjects which are going on. I should congratulate Parag and Sarita. Fantastic it is going on, Parag. The attendance is huge. The topic chosen are fantastic. And the subject, the sessions of different things. I think a good thing which has happened is Foxy is not doing any webinars. So the ICOG webinars, which are supposed to be highlighted, educative, academic, are getting huge popularity. It's not getting mixed up in the crowd of simple webinars of the chairpersons. I'm seeing it every time whenever I log in, 100, 200, 300 plus, Parag, fantastic. And these your conveners, all the three people are doing amazing jobs. Suman, Kavita, and JB Sharma sir. I think the way ICOG has become, it's like, when I was recently in a RCOG function and I realized RCOG is still a very, very small organization, not only with the quantity, the volume, the strength of the members, but also the way we function. We are much well organized with 75 years and ICOG, I think, Parag, for last 18 years.
No, 41 years now.
41 years. So, RCOG, the president only is heading the academic wing and everything. While here we are very well organized and fantastic. And I definitely feel it should be the way it is. And I'm sure with Parag and the efforts, probably we may come out with our own ethical committee, which is very, very important. So we'll keep on doing lot of publication work, keep on applying for Foxy. Today I saw 10 ICOG credit points. Any conferences of ICOG, there is a huge volume getting the fellowship of it. That also shows the popularity of it. And I'm thankful, Parag, for having me here and the team. And I congratulate the new ICOG members. And I wish, irrespective of anything, they should all the time be present in all the postgraduate courses or the academic courses or the certificate courses so that they know how it functions. And every mind is a creative mind. They can always give their inputs and come out with the brilliant ideas. Thank you anyway. This will be a great learning, pelvic urogynecology. I think we need it from bottom of my heart. I feel it belongs to us. The gynecologist should be expert and not the urologist. The patient should not be referred or going to the urologist. And that will happen when we create more and more awareness in gynecologist and hence with the patients. Thank you.
Thank you, madam. Thank you so much for joining and for sharing your pearls of wisdom. Thank you so much. So please share CBO Parag Viniwala sir. Sir is
No,
also
no,
very
forget. Don't share CV.
okay, sir is
I'll begin right
chairperson
away.
ICOG and he is PG teacher.
Kavita, that's okay.
Yeah. Okay,
No, that's
okay, sir.
Thank you.
Yeah.
Okay.
Sir
Good.
belongs to Pune and madam also belongs to Pune. Just I want to say these two things. So we are going to Pune in November.
No, Kavita, it is not me and he belongs to. We created this history now at least 41 years mein hua nahi tha. The Foxy president and ICOG chairperson from the
Yes.
same society.
Yes,
And
yes.
I don't
I
think
must
it will happen in another 50 years.
So I must congratulate both of you because both these academic as
History
well as
cannot be repeated.
yeah.
Thank you, Kavita.
Okay, sir.
Good evening.
Thank you.
I bring greetings from ICOG, and it's indeed a pleasure to address the gathering on occasion of the certificate course of this month on urogynecology and pelvic floor. First of all, thank you, Sunita, for joining today's program. And I always feel that when the president joins the program, it definitely adds a value. And of course, our conveners are motivated to do more and more. So there's a big competition going on because people
Yes,
want
sir.
to do uh, programs with ICOG, the master classes, the certificate course. So thank you for sparing your time and joining today. I must appreciate the efforts put in by my team, the conveners this time, Dr. Kavita Barnawal, chairperson of Urogyn Committee of Foxy for day one, Dr. Suman Sinha, who's the chairperson of Vaginal Surgeries Committee of Foxy for the second day. And third day, we have Dr. JB Sharma, who's the governing council member of ICOG. Of course, I also appreciate the efforts put in by the three coordinators, Dr. Meena Mahalingam, Dr. Sandeep Nikade, and Dr. Mukta Agarwal. I'm sure these 3 days are going to be really useful for us gynecologists. And by the end of the third day, we all will definitely be more confident in managing various situations related to urogynecology and pelvic surgery. So my best wishes for the program. Happy learning to everyone. And Sunita, just for your information, we have 455 registrations today. So probably more people will log in soon. So thank you and best wishes for the program.
Thank you so much, sir, for your wishes, for your blessings. So please, if Suvarna madam has joined, I can introduce her, or we can do it
Dr.
later.
Suvarna is not in India. She's abroad.
No, she
So
has
she
come
may.
back.
She's come back. Okay,
Yeah,
but
Madam is in
she doesn't
office.
seem to have joined.
Madam is in office, so
Yeah, madam
Okay.
is in office, but in busy in meeting. I will convey her to join in between.
Whenever
Yeah.
she logs in
Yes.
between two lectures, you can ask her to attend.
Yes,
That's
sir.
fine.
yeah.
Let's
So
begin the
should we
program.
start the session, academic session?
Yes, please. Yes,
Okay.
please. Let's begin.
Sarita Bhalera madam has also joined and she has blessed. So I think we should start the sessions, academic session. So
Yes.
Meena, are you there? So please share CV of Meena.
madam.
Meena is very active, and in fact, most of the urogynecological, just next. These things are being completed by Dr. Meena. I just start and she helps me a lot. So she has done training in urogynecology, macrosurgery, endoscopy, and she's instructor of basic newborn care resuscitation program. So yeah, okay, so Meena, just I request to start the academic sessions. So for session 1, you invite all the chairpersons and be on time so that we can complete all the academic.
Yes, madam. So now we'll start session 1. Like to introduce the chairpersons of the first session. Nilima, can you change the slides? We have
Yes,
three
ma'am. Yeah.
chairpersons, Dr. Anju Soni, madam, Dr. Asha Rao, madam, and Dr. Renu Gupta, ma'am, who will be taking over the first session and introducing the speakers. Dr. Anju Soni, madam. Anju Soni, madam, was the Vice President, FOGSI, in 2026. And she is the president of
Let's not waste time.
UMS 2024.
Just leave. Don't
Okay,
waste
okay,
time.
ma'am. Next slide.
Yeah.
Yes, ma'am. Asha, madam, CV. Director, Rao Hospital, Care, Coimbatore. Director for Postdoctoral Fellowship Program in Reproductive Medicine and Endogynecology, affiliated to Tamil Nadu. Yeah. Next, we have Dr. Renu Gupta, ma'am. Can you change Dr. Nilima? So, madam is the professor and head, Department of Obstetrics and Gynecology, GSVM Kanpur. Over to chairpersons to take over the session and introduce the speakers. Thank you, madam.
Thank you so much. Thank you so much. So it's my privilege to chair the first session of these 3-day certificate course of urogynecology and pelvic floor surgery today. Before I begin, I would like
ma'am, can you introduce the speaker, first speaker, Surbhi Vadva,
okay.
ma'am.
Yeah. You are inviting speakers, or we are supposed to invite?
Can you change the CV? Nilima?
Yeah. Okay. Yeah, so we'll invite the speakers. One second.
Surbhi Vadva. Nilima?
Yes, ma'am. It has changed.
Yeah. So there are speakers for the today's session. Dr. Shrikala Prasad, she'll be our first speaker, and she'll be taking us through surgical anatomy of pelvis and perineum. And then we have Dr. Surbhi Vadva. She will be talking about POPQ system, practical applications and limitations, a tool which we should all know how to use, must interpret wisely. Then Dr. Geeta Badirata, she will be giving the third talk and will guide us through choosing pessary for pelvic floor disorder, which, when, why, and often underutilized and highly effective modality. Then we have Dr. Karishma. She will conclude the session and will share her insight into the sling surgeries for the management of nulliparous prolapse, offering practical tips. And I want to say that I am feeling privileged to chair today's session. And because this topic is very, very close to my heart, the urogynecology 3 days certificate course is a need of an hour. And before I begin, I would like to sincerely thank FOGSI and ICOG leadership that for their inspiration, Dr. Sunita Tendulkar, dynamic and visionary president, Parag Benewale, our guiding chairperson of ICOG, Dr. Swarna, ever committed Secretary General of FOGSI, Professor Ashok Kumar, respected Vice President of ICOG, Dr. Sheila Mane, dedicated chairperson-elect, Dr. Sarita, ever energetic Secretary of ICOG, Their leadership and encouragements have made this academic program possible. And today, as we begin with the topic of pelvic anatomy, I just want to emphasize one thing. Understanding pelvic anatomy is absolutely crucial because the pelvis is not a bony framework. It is a dynamic region housing vital structure that form a foundation of women health. And the pelvic tissue and musculature provide support function for these three key organs, the urethra, vagina, and rectum. These organs are intimately related, and the supports are by muscle, fascia, and connective tissue. Any
Thank you,
disruption
madam.
in this
So
finely
thank you,
balanced
Surbhi. Surbhi will start, and thereafter Karishma, then Pragya Garg. In first session, these three speakers are Dr. Surbhi,
Yeah.
Dr. Karishma, Dr.
So
Pragya.
all the details. Yeah. Over
Surbhi
to
should
you.
start. Yeah.
Okay.
And Asha madam, then you will introduce
Yes,
Karishma
sure,
Sarani.
sure.
Okay.
Yeah, I'm here. I'm very much here.
Yeah.
Hi, Anju. Lovely seeing you.
Hi.
Hi.
Good afternoon, everyone. I hope I'm audible. At
Yes.
the outset, I would like to thank all the organizers for inviting me to present on the topic surgical anatomy of pelvis and perineum. Before we go into the nuances of the anatomy of the pelvis, let's just start with the. I'm sorry, but this doesn't seem to be moving. Just give me a second, please. Before we go into the nuances of the anatomy, let's just start with some of the important landmarks which we need to see in the bony pelvis. This is the tip of the coccyx, the ischial tuberosity, the ischiopubic rami, which we will be using hereafter, and the superior pubic of ramus, and in between them is the obturator foramen, the body of the pubic bones, and which are articulating with each other at the pubic symphysis. And here is this angle which is being formed out here, which is the subpubic angle. It has been stated that women with narrow pubic arch, which is less than 90 degree, are not good candidates for vaginal hysterectomy. At the same time, normal dimensions which are given in the Indian standard textbooks is about 85-degree angle, and the Western textbooks says it to be somewhere between 90 to 100 degree. Moving on further, the soft tissue, as Dr. Soni just mentioned, is the one which is more important for us right now. The first of the soft tissues which comes into the play is the perineal membrane. This perineal membrane was initially thought to be a trilaminar sheet or the urogenital diaphragm through which the viscera was perforating. But now studies have shown it's more dynamic than what it was earlier. It is now divided by various authors into a ventral portion and a dorsal portion. These are some coronal sections which have been taken, and we'll move from the ventral towards the dorsal end. At the ventral end, right here in the beginning, is what you can see is just the arcuate pubic ligament in between the ischiopubic rami. As we move further, the perineal membrane starts coming into picture ventrally, and below, that is caudally, it is fusing with the connective tissue of the vestibular bulb and the clitoris. Cranially, it is fusing with the levator ani muscle fascia, the attachments of the levator ani muscle onto the pubic bone, the arcus tendinous levator ani. Medially, it fuses with the walls of the urethra and vagina, that is, and the muscles of compressor urethrae and ureterovaginal sphincter muscles can be seen intermingled between the perineal membrane. As we move further dorsally, that's when the pubic rami tend to move away from each other. The ischiorectal fossa starts coming into the picture. That is when the perineal membrane now is seen as a discrete structure. So ventrally, it is intermingled with the rest of the connective tissue. Only dorsally can we see it as a discrete structure, is what is stated by these authors, Steen and Delancey. Over the pelvic membrane, that is cranial to it, then comes in the muscle, which is important, the pelvic diaphragm. Again, there is so much of nomenclature associated with it, with each book having its own names for the muscles involved. Traditionally, now the modern concept is again that is divided into an anterior portion and a posterior portion. The anterior portion consists mainly of oblique fibers which are running around the viscera, the rectum, the vagina, the urethra, and these are the pubovisceral fibers. The posterior fibers, which are of the posterior part of the pubococcygeus, the ileococcygeus, and the ischiococcygous, these are the supportive structures, while the anterior fibers are the ones which are involved in the movement of the urogenital hiatus, on the closure of the urogenital hiatus. Studies have shown that it attaches from a single thickening which is present on the obturator membrane, which is the arcus tendinous levator ani, which extends from the body of the pubis all down, all the way backward posteriorly to the ischial spine. This arcus tendinous levator ani is at a distance of 1.5 centimeters from the inferior margin of the ischiopubic rami. The attachments of these muscles are particularly important because that is what determines the function, and ultimately it's the function which is lost and seen as the symptoms when one sees. So the relationship between the component damage, like the pubo-vaginalis versus pubo-rectalis, and the symptoms which the patient would experience, like stress incontinence or rectocele, is all dependent on this attachment and the play of the muscles which is there. This is just an interesting photo which I found, so I just put it in my presentation. Over the levator ani, that is cranial to it, is the endopelvic fascia. It has been known by various names, but the modern concept is again to call it together as an endopelvic fascia, which is the fascia which is connecting these pelvic organs to the lateral pelvic wall, and it contains collagen, elastin, and non-vascular smooth muscles. It is penetrated by blood and lymphatic vessels and lymph vessels and nerves. On it, when we come to the attachment, it is attached anteriorly to the pubic bone. It is attached caudally to the perineal membrane. It gets attached to the perineal body, and it forms the superior fascia of the levator ani. As you can see, the arcus tendinous levator ani and the arcus tendinous fascia of the endopelvic fascia do not coincide with each other anteriorly. But as one moves posteriorly, they come together at the level of the ischial spine. The margins of the arcus tendinous can be seen 1 centimeter above the inferior margin of the pubic bone, in contrast to the arcus tendinous levator ani, which was seen 1.5 centimeters above the inferior ischiopubic rami. So the endopelvic fascia, as we just discussed, surrounds this vagina completely. So this is the cut section of the vagina, which you can see. And this is what was traditionally, this anterior posterior leaf is what was traditionally called as the pubocervical fascia. Posteriorly out here, we can see the rectovaginal fascia, and the dorsocranial extension of this endopelvic fascia are the cardinal ligaments and the uterosacral ligaments. When we talk about the pubocervical fascia, as we all know, the pubocervical fascia is attached to the pubic bones, and it supports the urethra, the urinary bladder, and the vagina by attaching itself to the lateral vaginal wall. The bladder pillars, that is the adventitia, which is present around the urinary bladder, gets attached to this pubocervical fascia by means of this bladder pillars. And this bladder pillars contain the terminal branches of the middle and the inferior vesical artery. Between the bladder and the anterior vaginal wall, out here is the vesico-vaginal space, one of the important spaces in urogynecology, which are used by the surgeons. The rectum itself is also surrounded by the connective tissue all around. The rectal pillars attach it to the endopelvic fascia, and out here between the posterior vaginal wall and the rectum are present the recto-vaginal space. If we were to pick on the vesico-vaginal space further, so here we can see laterally are the bladder pillars, and caudally it is marked, it's a closed space. Caudally, the attachment is where the vagina gets attached to the middle third of the urethra, so somewhere out here. And cranially is the supravaginal septum, which is separating the vesico-vaginal space from the vesico-cervical space. If once one cuts this supravaginal septum, the vesico-vaginal space and the vesico-cervical space come in continuity with each other. So authors have postulated that just like there is a rectoprostatic fascia, they wanted to find out if there was a vesico-vaginal fascia also. So a study in 2022 found out there was a fascia there called the vesico-vaginal fascia, which extended from the vesico-uterine pouch all the way down to the bladder neck. So just to give you the orientation, this is the posterior aspect, this is the anterior aspect, and what we can see out here is the uterus. So this is the vesico-vaginal fascia, and projections from the hypogastric nerves, which are meant to go to the urinary bladder, course anterior to the vesico-vaginal fascia, while those which have to go to the uterus are present laterally out here in this area. Now, before we move on further to the other extensions of the endocervical fascia, let's get in the ureter. So once we know that the pelvic ureter, when it's moving into the pelvis, is crossed by the ovarian vessels. Further, on the right side, it moves into the pelvis at the level of the external iliac artery, while on the left side, it enters the pelvis at the bifurcation of the external and the internal iliac artery. Thereafter, it runs along the anterior margin of the uterosacral ligament, tunnels through the cardinal ligament, and then enters into the trigone. So now we will look at the relations of all these structures and the organization of the uterosacral and the cardinal ligament and the trigone and the relations they have with the ureter. So the dorsocranial extensions of the endocervical fascia, which is the cardinal and the uterosacral ligaments. The uterosacral ligaments have been studied, and the direct anatomical measures have placed it to be about 12 to 14 centimeters long. It starts from the cervix and pans out all the way back to the sacrum at the sacroiliac to the S3 joint. This is the intermediate part, and this here would be the cervical part. At the cervical part, if you can see in this figure, it is continuous with the cardinal ligament. The cardinal ligament thereafter moves laterally, while the uterosacral ligaments runs posteriorly under the sacrogenital fold. It has been divided into a cervical portion, which is approximately 2 to 3 centimeters long, a longer intermediate section, which is 5 centimeters long, but very thin, comparatively thinner, which is only 5 millimeters, and the sacral segment, which is 5 centimeters long. Now, this is again the uterosacral ligament, and its relation one can see with the ureter. It's running along its anterior margin. This would be the sacral end, and this is the pubic symphysis. So at the sacral end, it's quite far away from the uterosacral ligament. It starts coming closer near the intermediate section. And when we reach the area of the cervix, the distance of the uterosacral ligament from the cervix is about 0.9 plus minus 0.5 or 4 centimeters. The ischial spine lies under the uterosacral ligament and is at a distance of about 4.9 centimeters from the ureter. These were the works of another prominent urogynecologist, which is Buller et al. Now, then there were also studies which were done to see the relationship of the uterosacral at the uterosacral ligament at the sacrum in the intermediate section and at the cervical portion. At the sacral level, if one was to see, the superior gluteal artery lies beneath it. These sacral roots of S1, S2, S3, as well as the sympathetic trunk lies medial to it. The pelvic splanchnic nerves and the hypogastric nerves are present lateral to it. Once we move on to the intermediate portion, below it would be the middle rectal artery and the ischial spine. That is, the middle rectal artery would be below the uterosacral ligament, and near the cervical end would be the ureter. This is the deflection of the uterosacral ligament, as you can see. And this is the organization, the structures which how they are organized in relation to the uterosacral ligament. Mapping of the structures which are present in the uterosacral ligament have also been done, because there's always a conflict between the anatomists and the gynecologists. The anatomists do not find any ligamentous structures, but it's actually a visceral structure. So again, to orient you, this is the pubic symphysis, this is the rectum, this is the uterus and the vagina. Now, if we move from medial to lateral, one would see that the connective tissue is present medially. The hypogastric nerves are intermediate structures, and the vessels, which are the visceral branches of the internal iliac vessels to the rectum, the uterus, the vagina, and the urinary bladder, are placed more laterally in the uterosacral ligament. So this is how the structures are organized. The cardinal ligament, again, is divided into its 3 portions. This is the proximal segment, the intermediate, and the cervical, which is the distal segment. These are divided on the basis of the entry of the uterus, of the ureter, and then the tunneling, the movement of the ureter into it through the intermediate part, and it exits out at the distal segment or the cervical ligament. The attachment of the cardinal ligament is to the lateral pelvic wall in a triangular shaped manner. At the apex of this triangle are the branches of the internal iliac. Running through its anterior border is the anterior first branch of the internal iliac artery. Running along its posterior border would be the inferior gluteal artery, and lying on the fascia of the levator ani is its base. Again, researchers have mapped the structures which are going to be present in it, and the ureter helps to divide the vascular stalk and the neural stalk from each other. The uterine artery and the superficial uterine artery, the superficial uterine vein, are present anterior to it. Then comes the ureter, if we are moving from anterior to posterior. Thereafter comes the deep uterine veins and the inferior hypogastric veins. I'm just winding up. This is the last slide. Below so where was I? So this is the ureter, and then there's the deep uterine vein. So one sees the deep uterine vein, one knows that below, posterior to it, would be the neural areas, which is the inferior hypogastric plexus would be present. So the organization in the cardinal ligament of the structures is from anterior to posterior, with the deep uterine vein helping to be a reliable marker to distinguish the vascular stalk from the neural stalk. The distal section, please note, once we see, which is medial, once it comes out of the cardinal ligament, this distal section has no important structures present in it. The pelvic ureter has also been mapped the length of it has been studied, and it is totally seen to be about 13 centimeters, which is of again importance to you, because if a catheter is passed and resistance is felt at 13 centimeters, then one knows that injury has been done to the ovarian vessels. If the catheter resistance is felt at 4 to 5 centimeters, one knows that the injury is due to the ligation of the uterine vessels, near the ligation of the uterine vessels, and at the vaginal cuff, that is 1 to 2 centimeters. If there is a resistance, then that is the vaginal cuff closure, which is the cause for the ureteral injuries. Once it enters into the trigone, again, this gentleman, Ran, has mapped the entire area of the ureter and the vagina. So the anterior vaginal wall has been mapped to be 8.4 centimeters. 3 centimeters, the first 3 centimeters of it from below going upwards is related to the urethra. The next 2.4 centimeters takes you to the interureteric ridge, and the Kefler-Moore structure. This is the site which is 3 centimeters above the interureteric ridge, is where in the trigone, usually above the trigone, where the urinary bladder usually gets injured during various procedures. So this is another relationship which one must keep in mind when performing these surgeries. So the main aim of the surgery, this thing was to give you an idea of how the structures are present within the uterosacral ligament as well as
Sorry
the
to interrupt you.
cardinal ligament. Thank you so much.
Thank you, dear.
Yeah,
That was an excellent overview, and it really sets the stage for our next talk.
Yeah.
Thank you so
And
much.
as we move for the next talk,
Sumana madam.
Yeah.
I hand over the
Hello,
talk
Sumana
to
madam.
Dr. Asha.
Can we take blessings from her?
Hello, yeah.
Yeah. So
Hi.
Sumana madam, Secretary General
Hi,
of
Dr.
Foxy.
Swarna.
Earlier she was
Hi.
president.
Good afternoon.
Good afternoon.
So Swarna madam, just bless. Yeah, Swarna madam, profession and head of the department, consultant and gynecologist, Bombay Hospital Institute of Medical Sciences. She is presently Secretary General. Earlier she was treasurer. We are well known.
I
to
think
her.
Kavita, let that be.
Okay,
Don't
so
waste
bless,
time.
madam. Just need your blessings. Thank you.
I don't bless. I'm not that big, but I really appreciate the hard work that you all have put in. This particular course on urogynecology and pelvic floor surgery. I'm just going through the brochure. What excellent topics you have designed, and what an excellent program that you have designed. And I really congratulate the conveners, Dr. Kavita, Dr. Suman, and Dr. J.B. Sharma, all three of them excellent experts in the urogynec and vaginal surgery. And also the younger generation of coordinators, Dr. Meena, Dr. Sandeep, and Dr. Mukta Agarwal. I really congratulate you for this excellent course that you have put in. For benefit of the attendees. I can see the attendees are more than, I think, 288 already, plus faculty 28. So great work, all of you. And urogynecology is always a difficult subject for general gynecologists. The pelvic anatomy itself, what an excellent lecture. I happened to hear the part of the lecture, and it was a very intricate anatomy was explained, and all of us know we start with anatomy, and the anatomy is the most difficult subject to understand of the pelvic floor and urogynecology. So I think you all have done commendable job, and once again I thank all of you for having great program, and of course Dr. Sunita, Dr. Parag, Dr. Sheila, and Professor Ashok Kumar, Sarita Bhalera have been a great support for these certificate courses. And I think more and more Foxy members should take these courses so that it will help
all the practitioners in their day-to-day clinical practice. So thank you so much for having me here at the this very program, a 3-day certificate program. Wish you all the best and all the success. Thank you.
Thank you.
Thank you
Thank you,
so
Dr.
much,
Suvarna.
madam.
Asha
Thank
Thank you,
Rabia.
you.
Dr. Swarna.
Hi,
Thank
Asha.
you very
Hi,
much.
Anju.
Hi, hi.
So
Asa
many
madam,
good.
please introduce
Hi,
Karishma.
hi,
We have
Kavita.
little time.
Dr. Sheila
I
Mane
can
madam has also
see
joined.
Shashi
Okay.
Hi,
Verma.
hi.
So
I
many
think,
people are there. Yeah.
yeah, I think whatever Dr. Suvarna says, I agree with her. The same feelings here. Yeah, Suman and Dr. Kavita have really framed the program, and the first lecture was awesome. I think the
Absolutely.
way
I know.
she described the anatomy, I think we feel, okay, there is so much to learn each day, and sitting in your own place, you're looking at it and learning so much. I mean, these opportunities are really we are all blessed with Foxy and ICOG, I must say. And more people should take advantage of it. It will, and the best part is it will be available on ICOG website. So
Very
those who
good.
have missed it also, and I know Dr. Suvarna has really worked hard towards all these things for years
Yeah, I
together.
think I
So
had started these webinars to be put on our ICOG website, so that people can take benefit of it. And
yeah, that's
sometimes
why I
I feel,
wanted to.
Sheila, I feel that surgery is rather technical job. But understanding pelvic anatomy is so important. Once you understand it thoroughly, I think surgery will just come to you like this. So I think that
Very
was a great beginning of your certificate course. All the best.
great.
Thank you.
All the best. All the best.
Yeah,
Same here.
Yeah.
Thank you. Yeah.
Yeah,
So,
CSCB
Kavita,
Karishma.
Asha
So
Rabia.
thank you, Dr. Vadhva, for a beautiful overview. And you have set the stage for the next talk. And as we may move forward and I hand over to Dr. Asha, I want all the attendees to think about these anatomical principles and connect it with your day-to-day practice. Over to you,
Yeah.
Asha dear.
At the outset, let me congratulate Dr. Kavita, Dr. Suman, and Sharma for having put up such a wonderful program, which all of us are enjoying. And urogynec is a fantastic area which was not much discussed earlier, and we are very lucky to be listening to this. And now we have a dynamic speaker, Karishma Taryani, who will speak to us on pelvic floor disorders, basic evaluation. She is the consultant from Center for Urogynecology and Pelvic Health. And her areas of interest are urogynecology, pelvic reconstructive surgery, and menopause. And
Thank you,
she's
Asha.
from Lady Hardin Medical College. I think let me not stand between the speaker and you. So let me present to you Dr. Karishma.
Thank you so much
Karishma, please.
for this very warm introduction. I am just sharing my slides. Are my slides visible? Are my slides visible?
Not yet.
Not yet, not yet. Now,
Yes,
yes,
now,
we can see.
now.
We can see them now.
Thank you so much. So, as you can see, my topic is assessment of pelvic floor disorders. We know that childbirth and aging in women are associated with pelvic floor disorders to the extent that up to 50% of women can have pelvic floor dysfunction. 1 in 3 will have urinary incontinence, 1 in 4 will have pelvic organ prolapse, and 1 in 5 will have fecal incontinence. Now, this is a very vast topic. Assessment of pelvic floor disorders is basic evaluation is basically divided like any other assessment into history, examination, and imaging. Because of the paucity of time, I will like to keep my, considering today's session is on prolapse, I'd like to concentrate on assessment of a woman with prolapse and keep talking about other pelvic floor disorders in between. Now, whenever we talk about history, like in any other disorder, the history should comprise of presenting complaints, but it should also include elicited complaints and history about treatment planning issues. Let us look at this one by one. For example, a woman with pelvic organ prolapse will usually present with complaint of something bulging out of her vagina. This will be her most common complaint. But as clinicians, to complete the workup, we have to ask her about symptoms related to the anterior vaginal compartment, middle compartment, and the posterior compartment. Let us look at these symptoms separately. Like I said, the most common complaint is the bulge symptom.
Your slides are not moving here.
Okay, ma'am, I can see them moving. I don't know. Should I read?
You are on the slide called assessment of
on the
PFDs.
assessment PFDs. You are on the slide of assessment of PFDs only.
Ma'am, I will just reshare it because they were moving.
Yeah, please reshare it, dear. Reshare it. So your slides were not moving.
I'm so sorry about this. Are
It's
they
okay.
moving
It's
now?
okay. It's okay. It's okay.
Are they moving now, ma'am?
Yes, yes.
Yes, now moving.
Okay.
Yeah,
So
yeah, absolutely
coming,
fine, fine. Fine,
thank
dear,
you.
fine.
Yeah. So like I said, the symptoms have to be divided into presenting complaints and elicited complaints. The most common presenting complaint in a woman with pelvic organ prolapse would be the bulge symptoms. 81% positive predictive value for prolapse. The patient will say that she has a sensation of something coming out, or she can see a bulge coming out, or she has pelvic floor heaviness. But at the same time, we also have to ask her about urinary symptoms. The urinary symptoms can be leakage of urine. In case she complains about incontinence, in her history, we should be able to differentiate whether she's leaking on the way to the bathroom, that is with urgency, or she leaks on sneezing, coughing. Does she also have increased urine frequency, nocturia, etc.? Then we come to voiding history. Is she able to, does she have any difficulty in passing urine? Is the stream weak? Does she complain of straining or incomplete passage of urine? Does she have to reposit her prolapse or stand and pass urine? Is there any pain or burning on passing urine? Similarly, we also have to know about bowel symptoms. And this history is same for all pelvic floor disorders, not only prolapse. Even in women with incontinence, all these histories are equally important. Coming to bowel symptoms, history of constipation, incontinence of stool, feeling of incomplete emptying, need to strain to defecate, digital evacuation, or splinting of vagina or perineum to pass motion. Similarly, sexual symptoms, is she sexually active or not? If she is sexually active, does she have dyspareunia? Does she have pain, reduced lubrication, or is she able to find pleasure during sexual activity? All these symptoms are also important. Presence of pain in the pelvic area, and if pain is present, any aggravating or relieving factors. Now, coming to other important histories, obstetric history is very important, especially about the mode of delivery, whether the patient had history of any perineal trauma during delivery, past medical history related to diabetes, pulmonary disorders, asthma, and other neurological disorders such as spine issues is again important. Drug history, there are certain drugs which can impact patients' urination, such as anticholinergics, antipsychotics, etc. Similarly, surgical history of previous surgery done for prolapse or incontinence. A lot of times patient knows that some surgery has been done, but they're not aware whether a mesh was inserted, what kind of procedure was done. So try to get the papers if possible. Whenever you're taking the history to objectify the patient's symptoms, it is best to use validated questionnaires. Questionnaires are available for prolapse, for incontinence, for fecal incontinence, for sexual dysfunction, and also for pelvic pain. Then coming to history about other treatment planning issues. These are patients' goals and expectations from the treatment. There's a 75-year-old lady who's sexually inactive and she has prolapse. Maybe a Leeford colpoclysis can be advised to such a woman rather than asking her to go for a mesh surgery. Similarly, if a woman is a marathon runner, she's 25, 30 years old and she leaks on running, she is not a patient who will benefit from only from exercises. She may require a surgical repair of her incontinence. So keep in mind the patient's cognitive functions, her support system, and her desire for treatment in all pelvic floor disorders. Now coming to examination, the patient can be examined in dorsal lithotomy, sitting, supine, or standing position, whichever position helps in eliciting her pelvic floor disorder the most. Always start with general physical examination, look at her BMI, look at her gait, look at the shape of her spine, because all these things have a bearing. Coming to systemic examination, look at the abdomen, look for hernial sites, any lump or scars of previous surgery. Then coming to the perineal examination, just look at the genitalia. Is the genitalia looking normal or is it gaped? In women with prolapse, gaping of genitalia, gaping of the introitus may be there. Whether you can see any, whether you can see the size, look at the size of the perineal body, look at this, look for any scar marks in the perineum, any soiling, any other sign which is visible on local examination on the perineum. If you can see the prolapse coming out, assess the prolapse mass for keratinization, ulceration, or any other growth on the prolapse. Whenever we examine for pelvic floor disorders, we first examine full bladder. When your patient is lying, just separate the vulva and ask her to cough. This is called the cough stress test, done comfortably full bladder. If you see a leak of urine, that is stress urinary incontinence. And if the prolapse is coming out in the same sitting, just deposit the prolapse back and ask her to cough again. If the patient did not leak before, she might leak now. This is called occult stress urinary incontinence. Inspect the perineum. Like I said, if you look at this picture here, you see that perineal body is completely deficient. Now coming to pelvic examination, once you have checked for stress urinary incontinence, occult SUI, now ask the patient to empty her bladder and ask the patient to do Valsalva or cough so that the prolapse comes out. A good way of doing it is giving the patient a mirror and asking her, is this the maximum prolapse that comes out? If the patient says yes, then that position is a good position. Otherwise, ask the patient to stand, maybe walk, so that you can see the maximum degree of bother that she has. Once the prolapse is out, the bladder is empty. In cases of incontinence, another important test to do is an empty supine stress test. That is, ask the patient to cough and see for any leakage of urine with empty bladder. If the patient still leaks with an empty bladder, that means that she has severe degree of stress urinary incontinence. Once the prolapse is out, look for the signs of estrogen deficiency. That is a thin, pale vagina, absent of rugosities. Then do a systematic speculum examination. A systematic speculum examination is then where you deposit 2 compartments and ask the patient to strain to see the maximum bulge of that compartment. If you look at the anterior compartment, Dr. Surbi did a wonderful job with anatomy. If we just use the knowledge of anatomy into a clinical practice, we will see that all these 3 bulges look alike. All 3 are cystoceles, but yet they are different and they have a clinical implication when we are operating the patient. The first cystocele you see here has no central rugosities. This is a classic example of pubocervical facial defect, which is centrally located. Look at this one. This has central rugosities, but it is absent bladder sulcus. This is an example where the pubocervical fascia has detached from its lateral insertion on the arcus tendinous fascia pelvis, the image that Dr. Surbi showed in the anatomy lecture. And this is the diagram of a patient who has apical, the pubocervical fascia is detached from the apex. So this differentiation is very important in the clinical examination, which will help you prepare for your surgery. Similarly, in the middle compartment, you can have subuterine descent, you can have a vault prolapse or an enterocele. Another thing important while seeing the middle compartment is to know about cervical elongation. 40% women with prolapse will have supracervical elongation. To be able to differentiate between supracervical and supravaginal and infravaginal elongation is very important while planning your surgical repair. Similarly, when you're doing a speculum examination for the posterior compartment, you may see a central defect looking like this, which is a rectocele. Or you may have an apical detachment where the fascia has detached from the apex, giving rise to, again, a rectocele. And this is an example of perineal hypermobility where the rectovaginal fascia is detached from the perineal body. It is important, again, to differentiate between these 3 different types of facial defects. Again, sometimes enteroceles are often confused with a rectocele. What you can do is you can use the speculum again and slowly retract the speculum to be able to differentiate between an enterocele, which is a middle compartment defect, and a rectocele, which is a posterior compartment defect. Now, if you see a picture like this, how would you describe it? Some may describe it as a 3rd degree cystocele, some may describe it as grade 2, some may describe it as cystocele plus. There's a lot of variation in our description. Therefore came the POPQ. I will not go into too much detail of POPQ because the next speaker will be covering it. But I think every postgraduate student, every urogynecology fellow has to know POPQ and should use it in their day-to-day practice. Then after doing the POPQ and staging of prolapse, next is the bimanual examination, which we all do, which we all know as gynecologists. It is to look at the uterine size, position, mobility, any other pelvic mass or pathology. Thereafter, another most important thing is assessment of the levator tone. You have to assess for levator tone to look at the strength, duration, and symmetry of contraction. Most of the patients will not be able to identify their pelvic floor. In such cases, you have to teach them how to use the pelvic floor. This will serve as a baseline measure and help you pick up patients who have weak pelvic floor and who can benefit from pelvic floor physiotherapy. This is a small video which shows how to look for pelvic floor assessment contraction. So you can see the finger and the thumb are here, and when the patient is asked to contract, you can see the lift of the thumb up. See here, the squeeze and the lift. Now this is graded by means of the Oxford score. This is the Oxford score, and again, this is freely available on internet. All postgraduate students should know about Oxford scoring, and it should be a part of your initial basic evaluation, whether it is a patient of prolapse, it is a patient of incontinence, or it's a patient of fecal incontinence. Oxford scoring is a must in all cases. Then coming to per rectal exam tells us about the resting tone of the anal sphincter. The voluntary contraction of the anal sphincter helps in differentiating about any anal sphincter injury, whether it is internal sphincter or external sphincter, any rectal mass, fecal impaction in patients with long-standing constipation. Once you've done with the per rectal, one thing that we all miss is a neurological examination. It is very important to always look for perineal sensation. Voluntary contraction of the muscle itself shows that the motor supply is intact, but there are two reflexes: the anal wink reflex, where you touch the perineal skin and you look for the contraction of the external anal sphincter, and the bulbocavernosus reflex, where you touch the clitoris and you look for the contraction of the anal sphincter, are both very important and should be done in all urogyne patients. If your patient has incontinence, as a part of your history taking an examination, an initial workup, a bladder dilatation. Last slide. Then comes the imaging, which is again, excessive imaging is not needed in urogyne patients. A basic ultrasound with post-void residual is usually enough for in most cases. But yes, if your patient has defecatory dysfunction, then she may require a defecogram to rule out pelvic floor dyssynergia. Imaging may be done if there are symptoms which are not matching your examination findings. Thank you. If there are any
Congratulations, Dr.
Karishma, you just answered the question in the chat box because we have limited us. So
it was an excellent talk, Karishma. We enjoyed it.
Thank you so much, ma'am.
So next speaker, please introduce Dr. Renu Gupta, madam. Are you there? Please introduce Dr. Pragya Gar. Renu Gupta, madam. If she's not there, then Madam Asha, madam, please introduce Pragya.
Yeah, I'm glad to welcome Dr. Pragya Gar, Senior Consultant Radiologist, Medanta, the Medicity Hospital, and she has also done fellowship in breast imaging, certificate course in fetal radiology, and she is going to speak to us on on transperineal ultrasound in management of gynecological disorders. I think it's a very important topic, and I welcome you, Dr. Pragya.
Meanwhile, till she's sharing her screen, let us all keep the previous two lectures, the way they have, given us the insight. We must correlate it with our clinical practice. That will, change the way we look at the urogynecological problems. So over to you, Pragya.
Yeah, 1 minute. I'll just. I'm sorry for the delay.
It's okay. It's okay.
Screen.
Then meanwhile, Dr. Kavita, let me congratulate you for having compiled this lovely program, because it's inspiring all of us. I was telling one of my colleagues, we have 4 consultants here. So I told this young lady, you have to come up in urogynecology. Please listen to the topics for the next 3 days and take some more interest in urogynecology. I think you're going to inspire many of us.
Yeah.
Somehow I'm not able to open share my.
Pragya, then they have ASIOG support team has your presentation. So can you share? Shreya or Nilima, are you there?
Madam Pragya ma'am's presentation we have not received.
Pragya, just now Pragya has shared, na?
Yeah, I just shared my presentation. I don't know what's going wrong now.
प्रज्ञा मैम, आपका पीपीटी पहले आप ओपन करके रख दीजिए.
पीपीटी ओपन करके रखें.
मिनिमाइज कर दीजिए. हाँ, ओपन करके मिनिमाइज कर दीजिए.
हाँ.
Just a minute, please.
आप ये
One minute.
आप शेयर करके since beginning slide share करो. अभी तो आपको दिख रहा है इनका तो.
प्रज्ञा मैम अब कीजिए आप. अब
नहीं,
पहले
मेरी
आप
बात
अपना
सुनिए.
पीपीटी ओपन करके
Can we
मिनिमाइज
नहीं,
कीजिए.
but can we meanwhile can we
I
invite
think I'm
another
able to
speaker?
share my screen now.
Yes.
Is my screen visible?
No, not
No, Pragya. Actually, we have to first of all open the presentation, minimize it, and then
This is my
do
presentation.
share and the slide share since beginning.
This is my presentation.
No, have you opened your presentation first?
Yes, it is. Yeah, my presentation is open in front of me.
हाँ मैम उसको मिनिमाइज कर दीजिए.
उसको मिनिमाइज करो.
हाँ
Okay,
फिर आप
minimize
फिर
कर
से
दिया.
जूम पे आइए.
Zoom पे.
हाँ
Share
वहाँ
option
पे
is
शेयर.
coming.
हाँ
नहीं, share
शेयर
screen पे
पे
आओ नीचे.
क्लिक कीजिए आप और वहाँ पे आपको
नीचे तो
पीपीटी शो हो रहा होगा.
Yes.
हाँ उसको क्लिक कीजिए.
Yes.
अब
Okay.
मैम उसको स्लाइड शो पे
how-
कर दीजिए. फुल स्क्रीन पे कर दीजिए. स्लाइड शो.
Pragya, go to slideshow. In the bottom of your presentation, there is a slideshow icon.
हाँ फ्रॉम बिगिनिंग.
Slideshow since beginning करो. Slideshow since beginning.
You see my screen now?
Yes ma'am.
Is
हाँ.
Is
No,
my
you are
screen
not in
visible?
slideshow.
Yes, open.
Yeah, good. You've done it.
Shreya, I
yeah,
think
good.
number has crossed more than 300 and many people are
Okay,
saying that
so-
they are not able to join. So what can they do?
Shall I start?
Yeah, you start.
start.
Shreya,
Am I
just look
audible?
into it. Yeah.
Am I audible?
You're
Yes,
audible.
yes, audible and
yes.
visible.
Okay. So, good evening, everyone. The topic for my presentation is role of transperineal ultrasound in management of urogynecological disorders. And I'm Dr. Pragya Garg. I'm senior consultant radiologist at Medanta Medicity. So, as we all know, ultrasound is the most widely used modality when it comes to radiodiagnosis, and more so in case of transperineal ultrasound because we can visualize the contents on dynamic imaging when a person is performing Valsalva. My first few slides are just for an orientation. This is when we are performing transperineal ultrasound, we do it in the supine position with the lady lying in lithotomy position. So this is the urinary bladder, this is the uterus with the endometrium, and this is the rectum, and over here is the pelvic floor muscles with the sacral spine. So this is how it is apparent. So over here is the urinary bladder. This is the urethra. We take pubic symphysis as the reference point. This is an axial uterus. I hope you can appreciate the uterus with the endometrium within. And this is I have taken this slide specifically because it has Nabothian cyst. The lady was having Nabothian cyst, so cervix is visible. This is the posterior compartment, which is the rectum and the anus. And behind that is the levator ani muscle. So, one more slide just for orientation. This is the pubic symphysis. This whole is the pubic symphysis. This is the urinary bladder. This is the bladder neck, the urethra. This is the vagina, the cervix, the uterus. It has a big fibroid here. In the posterior compartment, we see the anus. Below this would be the rectum. This would be the anorectal junction. And this is the levator muscle. So I'll just show one more slide. And this is a patient who had a hysterectomy. So we cannot see the uterus here, but we can very well appreciate the bladder, the urethra, the pubic symphysis, and over here was the vagina. In the posterior compartment is the rectum, and this is the anus, and behind that is the muscle, the levator muscle. So the most important utility of transperineal ultrasound in urogynecological disorder is that we can evaluate the movement of structures live as the patient is performing Valsalva. I'll this is a small clip showing the patient at performing Valsalva right now. I hope we can appreciate the movement of the bladder neck. Can you appreciate the movement of the bladder neck? See, the urethra, proximal urethra has moved up. This is the bladder, which is just moving. This was the pubic symphysis. This is the pubic symphysis, and see, I'm just playing the screen again. This is the pubic symphysis, this is the urinary bladder, and this is how the urethra as well as the bladder neck are moving. They have come below the pubic symphysis. This was the anorectal junction, this is the uterus, and this is the levator. And let me emphasize that whenever we are doing the scan, whole of our study is done with respect to a reference line which is drawn from the inferior margin of the pubic horizontally backwards. When we are moving backwards, there is no fixed point which has to be taken as a reference, but the line has to be perfectly straight, and the anterior aspect of the line is the inferior border of the pubic symphysis. So, what all can we evaluate? This is a lady, this is a scan of a lady. I have taken two images at rest, and this is an image at Valsalva. So when we're observing the lady at rest, we see that this is the pubic symphysis and this is the bladder neck. So we see this is the bladder neck distance at rest. But once she performs Valsalva, the bladder moves further down. It comes downwards, it crosses the symphysis pubis, and it moves caudally. So we can calculate that the bladder neck has descended. Moreover, the urethra, if we see, has moved inferiorly and posteriorly. So this lady has both the features, bladder neck descent and as well as urethral rotation. So when we see these features in a lady, it is this is one more example just to show that this was the pubic symphysis. This is the area of bladder neck. This was the bladder. This is the posterior compartment. This is the reference line which I was talking, that we draw from the level of pubic symphysis, horizontal line backwards. And after Valsalva, we see that not only the urinary bladder has moved down, the urethra has rotated posterior inferiorly, but there is descent of the rectal ampulla also. So all these descents have to be measured with respect to this reference line. Then there is one more thing which is of significance when we are talking about hypermobile urethra, that is angle of urethral rotation. Normally, if a lady is not having stress incontinence, there should be no more than 15 to 30 degrees of urethral rotation. But if we see in this case, which I had shown earlier, the angle of urethral rotation is 90.74 degrees. So if in my report I write that there is significant bladder neck descent with urethral rotation angle of 90.74 degrees, and then there is one more feature which we often see, which is called funneling. This is funneling. This is very well apparent on Valsalva, and funneling indicates that there is weakness of the sphincter. So if these three features are combined, that is the bladder neck descent. Significant bladder neck descent is called when it is more than 10 millimeters. Significant urethral rotation is said when it is more than 30 degrees, and funneling. They all are indicative of stress incontinence and would help in a urogynecologist in the management of the disease progression. This is another case in which lady had come to me with the symptoms of overactive bladder. So when such a lady comes with us, we ask the lady to pass to void urine and report to us. And then the first thing which we see after keeping the probe is how much residual urine she has. So if there is residual urine of more than 50 ml, 50 mils, it is significant. And the second thing which is calculated is the detrusor wall thickening. It is calculated at 3 points near the dome of the urinary bladder, and an average of all these three measurements is taken. And if it is more than 3 mm, it is considered significant, and it is an indicator of detrusor overactivity. So I like to play this clip, and once again, we have to see that this is the uterus. We could see the endometrium. This is the pubic symphysis. This was the urethra. And this is the cystocele which is forming. So this was the pubic symphysis. And see, just look at the urethra. There is some amount of funneling also happening, and a significant cystocele, as well as the uterine descent. So both these and anterior and middle compartments are seen to be prolapsing. And one thing which I would like you to see that in this is the urethra. As she's performing Valsalva, I'll show it on other slide. This was at the start of Valsalva, and this is when the Valsalva, she has applied extreme pressure, and she's holding the Valsalva for 6 seconds. That is how it should be done. We can appreciate that there is urethral kinking. The urethra is getting kinked. I hope everybody can appreciate this was the urethra at the beginning, and this is the urethra when the Valsalva was maximum. So this feature, when we look at this, we can also calculate a retrovesical angle. And in such a case, the retrovesical angle is acute. Normal retrovesical angle is 90 to 120 degrees. And when the retrovesical angle is acute, that means it is less than 90 degrees. It is called there is a classification of retrovesical angle, which goes by the name of Green's classification. This is type 3, Green type 3 classification with an acute retrovesical angle, and it indicates more of voiding dysfunction rather than stress incontinence. Whereas my next slide shows a open retrovesical angle. Dr. Karishma was talking about cystoceles and erythroceles, and she had shown an image also which was showing an apical defect. So if apical defect, you will see in this would be a type 3 type of cystocele, which would be very well seen on per speculum examination also, which has an open retrovesical angle. So simply by putting the probe and getting the lady to do a good Valsalva, asking her to hold for a minimum of 6 seconds, we can easily differentiate if her features are more towards stress incontinence or more towards obstructive, hyperactive, overactive bladder syndrome, and the treatment can be modulated accordingly. So I'm just showing you a case of 40-year-old nullipara but sexually active female. She had come to us with frequent UTIs. Where is my, this is a video clip. So this is the pubic symphysis. This is the urinary bladder. And this is the urethra. This is the urethra. This is the posterior compartment. This is the levator. There is no component of a middle compartment prolapse. But if you carefully see here, I have frozen an image here. This is a frozen image. There is a diverticulum which is forming. This is a diverticulum which is formed and which is which according to me is a cause of a frequent UTI, because this is not letting her void urine properly. Otherwise, there are no anorectal junction is well below the level of pubic symphysis. There is no middle compartment prolapse. Her muscle tone also looks very good. So this was a case of urethral diverticulum, which was leading to probably recurrent UTIs. I'll show you again. There is a case. This was a 38-year-old multiparous woman with mixed continence. The moment I had kept my probe transperineally on this lady, what we see is that this is the urinary bladder. It has some amount of urine here. This is, if I draw a line from the pubic symphysis posteriorly till the level of levator, I can see the cervix, which is very well prominent. The anorectal junction is also coming up. So just by putting my probe at rest without even asking her to do a Valsalva, one can get an idea that there is a lot of hiatal widening. And once she performs Valsalva, just look at it. The cystocele has gone way down. Way down. This is the hypothetical line, the line which we, or the reference line which we have to draw. She has triple compartment prolapse, the grade 3 cystocele, severe uterine descent, and a rectal prolapse also. So once this type of information is given to a urogynecologist, probably they will think of taking this lady for a surgery rather than just advising her Kegels exercise or otherwise. So all this while I was talking about anterior and middle compartment, posterior compartments can also be very well evaluated. And Dr. Karishma was talking in her talk about distinction between enterocele and a rectocele. So I'll just play this clip. Again, this is the point of reference, pubic symphysis. This is the urinary bladder, and we can see something herniating behind the urinary bladder, which looks like small bowel. It doesn't have the gut signature of a large bowel. And so this is how an enterocele looks. You can see echoes all over there. You cannot appreciate a good bowel wall here. I'll just I have a frozen image also. This was the reference line. This was the urinary bladder. We didn't see anything at rest, but the moment she exerted she started performing Valsalva. This thing came in between the rectum, that is the posterior compartment, and the anterior compartment, and this is an enterocele. So this is very well easily. And now, if I show you how a rectocele would look, this is a clip which is showing. This is the uterus, and this is the cervix. If you appreciate, this was the anus, this is the anal canal, and this is how a rectum. Over here was supposed to be the anorectal junction. I'll just play this clip again, and I would like you to pay your attention towards the posterior compartment. See, this is the posterior compartment, and this is how it is coming up. I hope everybody can appreciate this is the anus, and see, the more she is exerting, the more it is coming up. So in such females, the more they exert, I have a saved image also. See, this was the cervical descent portion. This is the posterior compartment, and this is a true rectocele, because this is an outpouching. A clear-cut diverticula is seen from the rectal ampulla, and rectoceles are also further graded into shallow rectoceles or true or deep rectocele. If the depth of the rectocele is more than 10 mm, it is called a deep rectocele. So here in this case, this depth of the rectocele, this diverticulum, the true diverticulum which is forming from the rectum is around 21 mm. So, and this lady would typically complain of obstructive defecation. She would tell me that she's, when she passes motion, she doesn't have that satisfaction of complete defecation. And the more pressure she would apply, the more width this diverticulum will take. So our advice our work to tell her should be that she should not exert that much during a defecation, because that way she'll make things worse for her. So that was a true rectocele and a false rectocele. This is a case of a false rectocele where this is the rectum. See, this whole of this is the rectum, this is the anus, this is whole. During Valsalva, whole of this rectum, rectal ampulla is shifted. It is not forming a pouch as it was forming a pouch in the previous study. So this is called perineal hypermobility, and as far as my knowledge goes, no specific surgical treatment is offered to a patient having perineal hypermobility. Whereas in cases of true rectocele, if one tends to correct the rectovaginal fissure, that gap, they can get easily cured. So now I'll be, after covering the anterior and the middle compartments, I'll be moving to the posterior compartment, which is the compartment where we can. I'll just be very fast now. So this is a compartment. This is the anus. This is the rectum, and this is the anorectal junction. And this also helps. All the images I'll be sharing now is from my work with Professor Hans-Peter Dietz. He's Hans-Peter Dietz, his wife, who is a sister, and this is me. So these are the images which I took when I was working there.
You already crossed 3.5 minutes extra.
Okay. So what should I do? I'll be very fast. Okay.
Kavita, can you advise her?
Yeah. Actually, Pragya, you have crossed 3.5-4 minutes. So I think you should stop now.
I'll just conclude with there's something called tomographic ultrasound imaging, which we can done once the probe is placed at the anus, and easily all the sphincters, external and the anal sphincter, can be visualized. This donut shape is the external anal sphincter. This black circle is the internal anal sphincter, and these are the images which are showing. This is the episiotomy suture, the normal one, and this is, we all know Abdul's classification of anal sphincter injuries. So this is when internal anal sphincter is also affected. It is called 3C, but this is a 3B. This is again, there is a disruption of internal anal sphincter. So anal sphincter injuries, obstetric. This is 3C because the internal anal sphincter, this dark circle also is gone. So this is a 3C type of injury. Levator can also be assessed just by putting a probe. So this is a case in which normal levator should be a uniform muscle strength. But whereas if we look at this doesn't look very uniform. It looks stretched over here. So this is a right-sided partial tear. This also is an image of levator injuries. This is how it looks. And levator area assessment also is very important, because once there is levator ballooning, the chances of prolapse correction 100% and recurrence rates are very high. So this was an image of a sling which was not well placed. So it was obstructing the urethra. This is the sling which was obstructing the urethra, and as well as sling pubic gap, which is supposed to be less than 15 millimeters, also is more than 25 millimeters. This again, so just by putting the probe and doing a 3D calculation, this was a case which I did yesterday. The lady had come and she was not sure whether
Again,
she had a
sorry to
tape or
say,
not.
you have crossed 6.5 minutes, so please,
Okay.
sorry.
So
Just continue.
slings can also be very well made out. This was all of it. Thank you. This is an image showing this MR and ultrasound correlation. Thank you.
I would add, now I would like to congratulate all the three conveners, Dr. Kavita, Dr. JB, and my dear friends, Suman, for organizing this beautiful webinar. And we all know that we don't want our patients gynecology to go to the urologist. We should be at the first end to treat them all. And all three speakers I would like to congratulate them. They have done the justice to their topic, and over to the organizers for the session 2.
So if Meena has not joined, please start sharing the CV of chairperson second session.
Meanwhile, Dr. Pragya, I invite you to Coimbatore to make a workshop on perineal ultrasound at Coimbatore.
Yeah.
You're most
So
welcome.
session 2, we have three chairperson, Dr. Anil Sakare sir, Dr. Rakesh Singh, and Dr. Paneet Khan. So Dr. Anil Sakare worked as assistant professor GMC Nanda for 11 years, and he is operating faculty of life surgical workshop in various national and international conferences. Next, second chairperson, Dr. Rakesh Singh, well known to all of us. She is governing council member of ICOG and vice chairperson of UP State Ishar, and she has credit of many awards. Next, Dr. Paneet Khan. His profession is study of OBG Society, Lakhimpur Medical College, Assam, teacher of undergraduate and postgraduate for 32 years. So I request any of you, like Anil Sakare sir, if I join, please introduce Gurnesh Singh sir. He will be speaking on principles of pelvic floor surgery. Anyone who has joined? Dr.
He was there.
Okay. Actually, there is some technical problem. Only 300 persons have joined. So let me introduce Dr. Gurnesh Singh sir. He is president of our OBG Society, former professor and HOD of Maharaja Agresar Medical College, Agroha, and he has more than 24 papers published, clinical experience since 1998 till date, and he has got many awards. So I invite him. He will be speaking on principles of pelvic floor surgery. So, Gurnesh Singh sir, please start sharing your slide.
Thus, chairpersons are not able to join. Topic which Dr. Gurnesh sir is going to speak on, and it's a lovely session which is going on. Congratulations, Kavita, Suman, and
Thank you. Yeah, please, Gurnesh sir, start sharing. Rakhi madam, you will introduce other speakers, okay?
Slide is not okay. I will start like
sir, you need to make it as a slideshow mode, the PowerPoint mode. Just click on that, sir. From beginning. Yeah, done.
Thank you, madam. I'm Dr. Gurnesh. I will be speaking on the principles of surgery, pelvic floor. I will be touching on integral theory system. What are the core principle of any pelvic surgery? It is anatomical restoration. That is, the damaged sports structure should be repaired as far as back to their normal position. Functional restoration, to restore normal vaginal function, so complete pelvic pain and improvement in sexual function may not occur. Symptom improvement, improve the symptoms of pelvic organ prolapse, such as bulging, pressure, incontinence, and thus improve the quality of life for the movement. Prevent recurrence, strategies should be incorporated in our surgery so that recurrence of the symptoms and the prolapse doesn't take place. Then comes what are the surgical decision-making factors. Patient-specific factors depending on the quality of the patient's general health, age, desire for future pregnancy, vaginal intercourse, or other risk factors for the prolapse recurrence like chronic cough, etc. Then type and degree of prolapse, that is severity and location of the prolapse, that may influence the type of the choice of this technique. Then surgeon's experience. The surgeon expertise and preference may play a significant role in the selection of the surgical methods. What are the different surgical approaches? Vaginal approach, often preferred because of reduced pain, shorter hospital stay, quicker recovery. Abdominal approach, larger surgical feet, but may lead to large extensive incisions. Minimal invasive approaches, laparoscopic or robotic, use small incision and advanced instrumentation for improved visualization and may result in less scarring and faster recovery. Repair techniques may use native tissue, mesh augmentation, or obliterative surgeries. Native tissues, especially in case of with mild risk patient, while avoiding mesh complication is a priority. Mesh augmentation, especially in the postmenopausal woman, when surgical mesh may help for the stronger support of the vaginal walls. Obliterative surgeries, leave-photocolpoclasis, like in those women which have frail older women and which may not desire vaginal intercourse. Then coming to the integral theory paradigm, the tissue strength. Basic principle is that ligaments are for structure and vagina is for the function. Why the integral theory came in picture? Because it was found when they do the surgery for the prolapse, they found that other things like dyspareunia, stress incontinence, also these problems got improved. So this led to the theory of integral theory, that if we give the treatment to the ligaments and the vaginal surgery, then multiple symptoms may improve. So basically, this is ligaments are for structure and vagina is for function. Traditionally, vaginal repairs involve excision of the vaginal tissues. Like for the repair of perineal body, some people may remove large V segments of the perineal body as a part of perineal body repair. In this theory, we say that vagina needs to be conserved and uterus as far as possible. Vagina is a weak elastic membrane, has a breaking strength of 60 milligram per square millimeter, and ligament has got strength of 300 milligram per square meter. The vagina gains its strength from the opposite stretching force, pubococcygeus muscle, levator plate, and the conjoint longitudinal muscle of the anus. Going with the same theory, the vagina is strengthened the support anteriorly, pubocervical fascia, suspended anteriorly by the pubourethral ligament, laterally by the arcus tendinous fasciae pelvis, and the cervix by the cardinal ligament. Posterior vaginal wall strengthened by rectovaginal fascia, suspended inferiorly by the pineal body, superiorly by the uterosacral ligaments, and laterally by the arcus tendinous fascia pelvis. Vagina is stretched to help open and close the urethra and to support the bladder stretch receptors. So if the vaginal portion is excised, this will lead to reduction in the quantity of elastin and collagen 3 and will reduce the function of the urethra and the bladder. So excess vaginal excision will either narrow the vagina or shorten it. If scarring is excessive at the bladder neck, the patient may develop teether vaginal syndrome, that is uncontrollable urine loss on getting out of the bed in the morning. So what is the key to surgical operation success in perineum is that structural strength derives from the ligament, collagen, and the function derives from the elasticity in the vagina. So vagina needs to be conserved because excising will reduce the quantity of elastin and collagen 3, and which cannot be recreated, and vagina does not regenerate. In menopause, collagen breaks down in bones and ligaments and is excreted as hydroxyproline. So it weakens the ligaments in case of postmenopausal women. What is the need of integral theory? Because before this theory, when the vaginal surgery was done using native tissue repairs or with the insertion of the mesh sheet behind the vaginal wall, very poor cure rate occurred at the region of 20% by the end of the 1 year. But when the post-operatively patients were evaluated, there was constant finding of laxity and atrophy of the uterosacral ligament. The cause which was explained was that descending uterine artery supports the uterosacral ligaments and it is ligated during the hysterectomy, leading to the atrophy of the uterosacrals. Integral theory tissue fixation system, it says that avoid vaginal excision and hysterectomy. And if the suspensory ligaments are weak, use tissue fixation system or mini sling tapes to strengthen these ligaments. The various studies were Inu et al., which shows that 87% anatomical cure of post-operative prolapse at 12 months and at 5 years, approximately 80%. Same study was replicated in Japan in 960 women aged 70 years, and the same results were obtained. Now creating a new collagen for the postmenopausal woman by harnessing the collagen 1 wound reaction to the implanted tape. Collagen 1 has the strength of 18,000 pounds per square inch. So when the ligament reinforcement with tapes is done, then because of the new collagen formation, the ligaments are strengthened. This is used as mid-urethral sling or the posterior slings, and it has been found that even if when you use number 2 or number 3 polyester sutures, some amount of neocollagen will also occur, and which will eliminate the requirement of the tapes. The ITP successfully cures or improves major symptoms, whereas there is only minor procedure using the same principles as the major prolapse. However, we must do the screening test first. What are the screening tests? We apply the hemostat vaginally to the periurethral area in midurethral area for stress incontinence. Or speculum is applied to support the uterosacrals for urgent chronic pelvic pain symptoms. If these are alleviated, then we should go for the surgeries for strengthening surgery for door ligament. So ITP indication for pelvic surgery are symptom based, and there is a simplistic algorithm diagram. This basically shows that if there is anterior compartment failure, then we should strengthen the pubourethral ligaments, middle, then pubocervical fascia and cardinal ligament, and posterior, then uterosacral ligaments. So what is the paradigm? The integral theory says that ligaments of vagina has got different role in pelvic floor function and so require different surgeries. Ligaments are structural, so shortening and reinforcement act to firm insertion point for the muscles which contract against them. And excellent results are achieved for anatomical and symptomatic cure by native plication of the cardinal and uterosacral ligaments with vaginal conservation, but only in the premenopausal woman. In postmenopausal woman, because there is a collagen breakdown, there is a poor strength in the native tissue, so we may require reinforcement with collagen creating tapes for longer time results. Or we may also use wide bore polyester sutures. Vaginal conservation. Vaginal conservation is basically vagina is functional. It mediates closure and opening of the urethra and has key role in controlling the afferent output of the urothelial stretch receptors, which may lead to the inappropriate urgency. So when you remove the vagina, you remove the elastin and the collagen for the optimal function of the vagina. So vagina must be conserved. Same way, if you use mesh sheets for retaining the elasticity of vagina, they lead to the fibrosis and the elasticity is reduced. And excessive excision may cause scar tissue and fibrosis, which may lead to tethering vaginal syndrome. Reassigning excess vaginal tissue instead of excision. So for this, there was a 10-year experience in this study where 3,100 midi-sling tape implants were used for 3rd and 4th degree organ prolapse, and they repaired only ligaments instead of excess vaginal tissue. Concertina technique was used for saving the vaginal tissues, in which the the epithelium is stitched with the underlying facial tissue, and after 6 weeks, the intraepithelial collagen and the glycoaminoglycans readjust to the forces acting them to give a good result postoperatively. This is a concertina suture in which you can see that one suture goes through the vaginal epithelium, then to fascia, then again to fascia, and then the vaginal epithelium. You use the 2-0 Vicryl to full stitch it. It can be continuous or it can be interrupted. Now, uterine conservation, uterus and uterosacral attachment provide a firm structural anchoring point downward to downward muscle vectors, which are so important for bladder and anorectal function. Hysterectomy requires sanctioning of the descending uterine artery, which support the uterosacrals at their insertion point. So it is not uncommon to find atrophic uterosacral after the hysterectomy. It has been found that women who have had hysterectomy are known to have more serious bladder, bowel, or incontinence after the menopause. Now, after 2011, there was a major drive in many nations where they went against the tapes for the mid-urethral slings or mesh sheet for the prolapse. It began in the mass media and gathered sufficient momentum for a complete ban. These decisions have left vast majority of older women with only surgical option of native tissue repair with high failure rate. So it proposed tension-free artisan tapes. What are the tension-free artisan tapes? They are 8 to 10 millimeter wide, 10 centimeter long muslin tape cut from the last sheet of propylene mesh, and they are directly applied in the position of the damaged ligament without any tension. The symptom in the 3 zones of vagina are a good guide as to what ligament may be need repairing. The ligament is located, a tunnel is made along the ligament on each side, and tape is inserted tension-free equivalently on the each side with a hemostat, and vagina is closed with a Vicryl suture. These are the tension-free tapes which are given for the different ligaments. These are the pubourethral ligament repair. It has been shown midline vaginal incision, retropubic mantle dissection, and you can see the introduction of the tape in the pubourethral ligament. Then this is a cardinal ligament. We have separated transfer incision on the vaginal wall, and there is a separation from the cervix and vagina. Then introduction of the tape and stitch of the vagina. This is uterosacral, plication of the uterosacral up to the cervix, and creation of tunnel in relation to the uterosacral, and introduction of the tapes. So white bird number 2 and number 3 polyester suture also can be used instead of muslin tape.
Sorry to interrupt
Initial
you,
results
sir.
are
Your
good.
time is up.
1 second, ma'am. Last slide.
Okay, sir.
So, what is the shortcoming of integral theory? The problem is that it goes on speaking about ligaments only. It doesn't take care of other like nerve pathways, pudendal neuropathies, muscle damage, etc. So today, contemporary urogynecology faces multifactorial model with pelvic floor dysfunction. It incorporates integral theory and includes anatomical and the neurological factors also. Conclusion, key surgical principles are ligaments are for structure and vagina is for function. Prolapse and symptoms are related. Repair the structure, you will restore the function. Avoid vaginal excision and hysterectomy. In post-menopausal women, create new collagen to and reinforce damaged ligaments. Thank you.
Thank you, Dr. Gurneesh, sir. And it was indeed a good and a practical learning for us, all of us. And keeping the time in mind, let's move on to the other next lecture. Can we have the CV of Dr. Suman? She's going to speak on POPQ practical applications and limitations. And we all know Dr. Suman Sena. She is the chairperson of Vaginal Surgeries Committee of FOXI and member of the Research and the Good Practice Committee of CEPHOG and senior consultant Ops and Gynae at AHIVF and Infertility Center, Ranchi. Over to you, Dr. Suman.
Thank you, Dr. Rakhi. Allow me to share my slides. Can you see my slides? So, can you see my slides?
Yes, ma'am. Make it full screen, ma'am.
Yeah, I'm trying to make it. Just a minute. Give me 1 minute. Yeah. Is it okay?
Done.
Yes, ma'am.
Let's see, it's moving or not. Yeah, it's moving. So, good evening, everybody. Thank you, Dr. Rakhi, for the very warm introduction. And at the very outset, I'd like to thank our Foxy President, Dr. Sunita Tentalwarkar, Madam, ICOG Chairperson, Dr. Parag Biniwale, Chairperson-elect, Dr. Sheila Mane, Vice Chair, Dr. Ashok Kumar, Secretary ICOG, Dr. Sarita Bhalerao, all my conveners, Dr. Kavita, Dr. J.B. Sarma sir, my coordinators, all the faculties over here, and dear viewers, today I'll be talking to you for the next 15 minutes on POPQ, its practical application and limitations. So one of the main problems concerning the prolapse of pelvic organs is the need for a universal, clear, and reliable staging method. Several attempts were made by different authors during different periods to bring an ideal classification system for staging of pelvic organ prolapse. So you can see here the history of pelvic prolapse classification. 1963, there was the Porges system, which was severity prolapse assessment system. Then 1972, Baden-Walker halfway scoring system. Then 1980, Wickhams classification, and 1996, which we are going to discuss, was proposed by Bump et al. That is the POPQ. And then we have also seen the Soares, Jacquards, and Malpass classification. Now we all know the symptoms of prolapse. It depends upon the anatomical site. So POPQ is the new era in pelvic prolapse staging, and it is very important because classification necessary for documenting, comparing, and communicating clinical findings with inter and intra-observer reliability. Ideal quantification system should fulfill all the above criteria, and this POPQ system has been approved by American Urogynecological Society and the Society of Gynecological Surgeons. So what is the objective of POPQ? It is for the quantification of prolapse, to compare outcome of surgical repair, for the inter-individual reliability, and also for the standards, for written publication and scientific presentation. So how does POPQ work? So the topography of vagina is created into two planes, the sagittal and the horizontal. We all know in the sagittal plane, hymen is taken as the reference point. Anything proximal to the hymen is in minus, anything distal to the hymen is in plus. And in the horizontal plane, it is taken from the urethral meatus to the posterior midline hymen, and from the posterior midline hymen to the mid-anal opening. So how POPQ system works again? The hymen acts as a fixed point, we all know now, and 6 points are located and 3 measurements are made in relation to the hymen, which is fixed anatomical landmark. Anterior is A, BA, and C. Posterior is AP, BP, and D. And 3 other landmarks are GH, TVL, and PB. Each is measured in centimeter. The hymen was selected as the reference point rather than introitus because it is more precisely identified. The terminology avoids assigning a specific label such as cystocele or rectocele to the prolapsing part of the vagina, acknowledging that the actual organ above the prolapse cannot be frequently determined by a physical examination. So how to interpret these points? Point A and BA represent the anterior compartment defects. Point C and D represent the middle compartment defects. And the area between A and B represent the extent of pubocervical ligament. Point AP, BP represent the posterior compartment defect. So this is a normal picture, and there is no prolapse, and we can see all the points and landmarks, which is important for POPQ system examination. And now how to measure the, now let us describe all the points. A is a fixed point on the anterior vaginal wall, and it ranges from -3 to +3. And BA is the most dependent distal portion of the rest of the anterior vaginal wall, and it ranges from -3 to +TVL. AP again is a fixed point on the posterior vaginal wall, and it is -3 centimeter from the hymen and ranges from -3 to +3 centimeter. BP is most dependent distal portion of the rest of the posterior vaginal wall and ranges from -3 centimeter to +TVL. And C is the most distal edge of the cervix for vaginal cuff or vaginal cuff if cervix is absent, and it ranges from minus to plus TVL. Now D is posterior fornix corresponding to the pouch of Douglas, and this point is omitted in absence of cervix. TVL is the greatest depth of the vagina when point C or D is reduced to its fullest position. GH is from, I've already told, and PV I've already told, they all are measured in centimeter. And this is, in this picture, we can see the leading leading distal edge, and if the uterus is intact, then it will be cervix, and if there is no uterus, then it will be the vaginal cup. So how to measure now? So except for the total vaginal length, that is TVL, all measurements are made with patient in dorsal lithotomy position with maximum protrusion of the genital organs achieved by telling them to strain or to do the Valsalva maneuver. And we can use either a sponge holding forceps or pap smear stick or marked cotton tip applicator, and they all are marked from 1 in centimeter from 1 to 10. And a marking pen is used to mark the points, and points, what are the points? We already know now, that is A and BA. For A and BA, what we'll do, we'll depress the posterior vaginal wall by a single blade speculum, and patient is asked to perform maximum Valsalva. For measuring AP and BP, similarly, after retracting the anterior vaginal wall with the same speculum, GH and PV measured during Valsalva maneuver. Only TVL can be measured when patient is relaxing. She will not strain, and will place the graduated ring forceps at the vaginal apex and note the distance from the hymen. And we can see the measuring device. This is our pap smear spatula, which is wooden, and this is the Sims speculum. And we can see here how GH is being measured. Now point C and D measured after inserting a bivalve speculum up to the vaginal apex. So positive points below or distal to the hymen, and negative points above or proximal to the hymen. Now, after all 9 points are taken, a stage can be assigned to each compartment, anterior, middle, and posterior, and the degree of prolapse is quantified using a 5-stage ordinal system, and we can place them on the grid like this diagram. You can see this diagram and take a picture of it. I will describe it in later slides. So when there will prolapse of AABA, there will be anterior compartment prolapse. Prolapse of AP and BP will be posterior compartment prolapse, and prolapse of C, TVL, or D will be apical prolapse, and there will be change of shape of perineum during prolapse, that is the GHLPB. So how to describe now? By Popke quantification. Stage 0, there will be no descent of the pelvic structures during straining. Point A, BA, AP, BP are all at -3 centimeter. Either point C or D is between the TVL and TVL -2. In the stage 1, the leading surface of the prolapse does not descend below 1 centimeter above the hymenal ring, and most distal part of the prolapse is more than 1 centimeter above the hymen, and the quantification value is less than -1 centimeter. For stage 2, the leading edge of the prolapse extends from 1 centimeter above the hymen to 1 centimeter through the hymenal ring, and the most distal portion of the prolapse is less than 1 centimeter proximal to or distal to the plane of the hymen, and the quantification value will be more than -1 centimeter but less than +1 centimeter. For stage 3, the prolapse extends more than 1 centimeter beyond the hymenal ring, but there is not complete vaginal eversion. So the most distal portion of the prolapse is more than 1 centimeter below the hymen, but protrudes no further than 2 centimeter less than the TVL, and the quantification value is more than +1 but less than TVL -2. And for the stage 4, the vagina is completely everted and quantification value is more than plus TVL -2. So this is a diagram. I've tried to show the stages of apical prolapse. And you can see very nicely, I have shown you the TVL. Patient is relaxed and measured it with a wooden spatula, and patients relaxed. We can see the TVL, the apex of the vagina, and the hymen, and the distance is noted. And the patient was asked to strain, and again we measured, and this was the C. And when we asked patient to strain, and we saw the leading distal part has descended, but it is less than -1 centimeter. This is stage 1. If it has descended 1 centimeter above and 1 centimeter below the hymen, then it is stage 2. It has descended below +1, but it is still less than TVL -2, then it is stage 3. And if it has descended more than TVL -2, then this is the stage 4. So now coming to the very important tool that is known as PopQ tool. It is an interactive assessment tool. It is a flexible application and lets you enter PopQ scores, visually demonstrates the captured measurements for the patients, educate patients before and after surgery, and print out patient-specific results. So here you can see a diagram of PopQ grid in a prolapse uterus, and if there is no prolapse, the B figure is without prolapse. So here we can see all the points are in normal position. A -3, BA -3, C is at -8, at B, GH is 2, PB is 3, TBL is 10, and AP is -3, BP is -3, and D is 10. So this is normal and there is no prolapse. Whereas you can see here in A there is prolapse because A is +3, BA is +8. In the posterior compartment, you see AP is +3, BP is +8. So it is anterior wall prolapse as well as the posterior wall prolapse. Here clearly you can see the anterior wall prolapse. In this grid you can see the posterior wall prolapse. So coming to the criticism, which I have been told to explain, it is limited ability. This PopQ quantification system has limited ability to quantify the prolapse itself, since it still classifies prolapse into 4 stages, almost same way as older classification. Staging is quite complicated. The reference point is hymen, which is not seen in most women with prolapse. The term introitus should be used to represent the opening of the vagina. Lateral vaginal wall prolapse is not addressed here. A few more deficiencies: does not identify and document unilateral and asymmetrical defects. Despite recommendation by ICS, only 40% members of ICS used it in their clinical practice, and patient position affects the result. Advantages are also there. The previous classification system were criticized for being unstandardized and that they cannot be used for comparing information. Terms used previously were imprecise, inaccurate, and often misleading. Therefore, new system of classification with standardization of terminology was proposed. PopQ facilitates communication between physicians in practice and research and enables progression of this condition to be followed accurately. Two important advantages over previous grading systems are it allows the use of standardized technique with quantitative measurements as training relative to a constant reference point, that is the hymen. Its ability to assess prolapse at multiple vaginal sites. So take home message is PopQ allows for more accurate assessment for post-operative outcome, ensures uniform, reliable, and site-specific description of the pelvic organ prolapse. So thank you very much for your patient hearing. I hope I was in time.
Thank you, Dr. Suman. You were very well in time. And thank you for nicely elaborating and explaining the PopQ score. I hope all the postgraduates must have definitely got benefited with it. We've got the next, is the other chairpersons available? Dr. Anil Sakre or the other one?
Dr. Anil Sakre, I can't see him.
Anil sir is there.
Either, yeah, then tell him to, okay. So Dr. Anil, you
Yeah,
can.
yeah. Yeah. It was a really nice lecture by Suman ma'am, and she finished it in within a time. But really, an understanding to all postgraduates and the youngsters to how to measure the PopQ in case of pelvic organ prolapse is very important because it reflects your how you correct it while doing a surgery. So PopQ is a mirror of your surgical outcome also, and understanding pelvic organ prolapse with PopQ is very easy rather than describing prolapse in grade 1, grade 2. Really a wonderful attempt by Suman ma'am to explain it in such a nice and simpler way. Thank you, ma'am.
Dr. Anil, would you like to introduce the next speaker?
I am fortunate to introduce Dr. T. Srikala Prasad ma'am. She is a retired professor and HOD of Urology, VP South Zone, South Sea. She worked at the government Kilapuk Medical College. She has very big academic achievements like Best Paper Award, Management of Stone Disease in Pregnant Patients, Best Paper Award, The Landscape of Pelvic Floor Disorders in Adult Women and Comprehensive chapter in urogynecology simplified, and other chapter in. Can you hear me? Hello.
Dr. Anil, go on. We can hear you.
Yes, sir.
Yeah. So she has also written chapter on urological injuries in OBGYN practice in a book on medical legal updates in OBGYN. We welcome Dr. Sri Kala Prasad ma'am on this dais. Welcome, ma'am.
Thank you, sir. Thank you for the nice words of introduction. Am I audible?
Yes.
Yeah, ma'am. Yeah.
Okay. So shall I share my screen?
Yes.
So there are many different ways of tackling a pelvic organ prolapse in women of reproductive age. Since there is another topic on sling surgeries, I am now restricting myself to Fothergill repair. Fothergill indications are in Paris women with lesser degrees of pelvic organ prolapse and those who are desirous of uterine preservation surgeries, it is more useful in women who have elongation of cervix, and it is a safer option in women who are mesh aversive. So what are the contraindications? Because we are doing a uterine preserving surgery, we should mostly rule out any women having an abnormal or a postmenopausal bleeding, an endometrial pathology, cervical dysplasia, tamoxifen therapy, those who have cancer, and those who are unable to come forward. Proper case selection is very important, very useful in women with cervical elongation, stage 2 or 3 pelvic organ prolapse, and you have to have a full informed consent. And we really don't have a full data on the need of cervical encerclage or the mode of subsequent delivery. We have to do a routine investigations with a special emphasis on a good ultrasound and also an endometrial evaluation. So I will go into the video. Preliminary DNC where sounding of the uterus, which assesses uterocervical length, the cervical length, and how much elongation is there is very essential. Dilatation will help the lip formation, proper drainage of the os of menstrual fluid, and prevent stenosis of the newly formed external. As you will get a special the video for to save time. So preliminarily, see, I'm doing a dilatation. I'm just putting a dilator. I'm using a thick dilator whereby I will know, I can measure. I will not initially dilate. So I will know what is the total cervical length. Then I also dilate, and at the same time I do an endometrial curettage. As I was telling you, we get all those factors. Now here you can see I have put a transverse incision on the cervix at the junction at the sulcus, and then I'm mobilizing the pubic ligament. Okay, and here you can see this area will be firm, but this will be the soft loose fold. So if you cut the posterior vaginal wall, you can do a posterior colpotomy, and opening the Douglas is very useful if you have a enterocy. The next important step is to clamp, cut, and ligate the McEnroe's ligament. I am a person who use sutures. You can, in fact, this is very useful because you have the suture on a hemostat, so that subsequently you can bring it in front of the cervix. So it's better to do ligation the use 10 on the other side also. The uterosacral ligament and McEnroe's ligament is clamped, cut, and ligated. This woman, she did not want a baby. So here you can be little liberal when you cut the cervix, but otherwise, when you measure the total cervical length and the cervical length, you have to retain a cervical length. The neo-cervix should be at least 2.5 centimeter. Now I'm trying to do a cystocele. I've done a hydrodissection. I use normal saline with adrenaline or xylocaine adrenaline. After hydrodissection, you can put a midline vertical incision and reflect the anterior vaginal wall from the underlying cervix. You can see that the vagina is thick And because of the hydrodissection, you can see it is getting easily pushed nicely. You can use a scissor, diathermy, or the knife. Now, when I'm doing the cystocele repair, the lowermost is here. So I'm taking that, I'm doing a imbricating suture on the fascia, the pubocervical fascia. Can you see? I'm starting from below. I'm tightening that pubocervical fascia. Now you know where you are going, you are cutting, you have clamped the Mecan rods, you know where you're going to cut. So above that, I will anchor it to the cervix. So not only plication of the cervix, you can fix it, plication of the pubocervical fascia, fix it onto the neocervix. Then from below upwards, I'm doing rows of plication sutures of the pubocervical fascia. Thereby, we do a cystocele correction. I use 20 Vicryl is what I'm using, but you can also use 20 PDS. So I'm anchoring that first stitch also to the bite I have taken on the cervix so that it gets well anchored. So again, I'm continuing the cystocele repair from below. See, I'm taking bites on the pubocervical fascia. It is the adventitia overlying the bladder. I'm not taking it within the bladder. I'm just taking it on the pubocervical fascia alone. So by imbricating sutures, by taking rows of sutures, you achieve a cystocele correction. So again, you can see, even if there are some minimal bleeding in between, by the time we imbricating sutures tight, the bleeding settles. So whatever sutures I have taken from the hemostat, I am tying. You can see that the cystocele is getting reduced well and it becomes well supported. So now I'm adding cervical amputation. If this patient desires to have a baby, then I will ensure that the new cervix is around 2.5 centimeter. I'm again confirming the dilatation so that there is no stenosis. So now we are forming the cervical lip, taking a bite on the Mecan rods and the uterosacral ligament, and I'm doing the Sturm-Dorf suture. Taking a bite on the cervix. This is on the Mecan rods ligament on the other side, and then I'm bringing it out of the vagina. Now to reverse the cervix, I'm just going to cover if when I do the posterior, you'll see how I'm bringing this clock position and then onto the cervix. The main thing is like, putting a blanket over a bed sheet over our mattress. I'm going to cover this posterior, the vaginal wall all around on the neocervix. That is what precisely we are going to do. And even if it is little not covered, by the time they come for a follow-up, you will see it is really well covered. Because even if you do a leap, you see subsequently when they come, it is well covered. But now you can see that as I take these bites, can you see the cervix is being covered beautifully with the vagina. The whole vagina is just into and cover it. The aim is to cover the cervix, the neocervix vagina. Again, I'm taking a lip on the post-vaginal wall, and then I will take a lip on the cervix and then bring it, cover it. You can see it is coming out of the cervix through the vaginal wall and tight.
Madam,
the
voice is
vagina was
breaking.
reflected.
And the internet is lagging. The video is moving very slow in different
Okay.
pace. Your voice.
Okay. I don't know whether I should move a little forward. They say the video is moving very slow. Shall we go in front and see? I will just try to move to another place. The thing bring it out and see if I'm able to. If you're able to see it better, I choose another place. What you need to know is you cover the neocervix. And now I'm cutting the redundant vaginal wall anteriorly. So a little bit adjustment here and there so that you can cover it well. Is the video better? I have moved to another place. Madam, is the video better now?
It's stagnant right now.
For me?
Moving, it is moving.
Slow movement. It's moving slowly.
Okay. So I have covered it all around. Now I'm going to do a posterior colpoperineography. You can see I'm making the incision within the hymenal ring so that the suture will not be painful on the skin area. Reflecting the posterior vaginal wall from the underlying cervix. I'm doing a rectocele repair by taking imbricating bites on the rectovaginal fascia. I had got the superficial transverse perineal muscles below. I have tied that also. Now I am closing the posterior vaginal wall. And you can see that the cervix is at the level of the ischial spines. And the vagina was admitting 2 fingers nicely. so that she will be able to have a painless contact also. Thank you.
Thank you, Srikala madam. And at the outset, we've come to the fag end of the session 2. And I would like to thank Dr. Sunita madam, President Foxy, Parag Beniwale sir, who is the chairperson of ICOG, Dr. Sheila Mane, vice chair, Dr. Ashok Kumar, vice chair, and Sarita Balerao ma'am, who's the secretary, and all the conveners.
Actually, I think my talk is still balanced.
Oh, we've got, I'm sorry, got one more speaker. I'm sorry. Dr. Rajendra, how can I forget Dr. Rajendra Sarogi, sir? And he is a professor, emeritus professor at SAIT GS Medical College, KEM Hospital, Mumbai, ex-honorary head of the department.
Okay, don't bother about all those things now. Let's go ahead with it.
Senior consultant, Nanavati Hospital, Mumbai, and director of the Sarogi Group of Hospitals. Over to you, sir.
Thanks a lot.
You're going to speak on steps to be taken to prevent wall prolapse.
Yeah, I think they will have to present my slide.
Yes. Yes,
And
Shreya.
maybe we have
Yes,
to
sir.
move the slide.
Yes, sir. Yes, sir.
Yeah, kindly show Dr. Saragi sir's PPT.
And when I tell to move ahead, then please move. Next. I'll keep telling you next.
Yes, sir.
And here, respected Dr. Sunita Foxy, ICOG President, Dr. Parag Biniwale, Chairperson ICOG, Dr. Sheila.
Sir, you are muted.
Sir, you are muted, sir. Not audible. Sarogi, sir. Sir, Rajendra Sarogi, sir. Can Nilima unmute, sir? Yes. Sir, now you are audible.
Now you can hear me?
Yes, sir.
Okay. Respected Dr. Sunita Foxy, ICOG President, Dr. Parag Biniwala, Chairperson ICOG. Just a sec. Dr. Sheila Mane, Chairperson elect ICOG, Secretary General Foxy, Dr. Suvarna Khadilkar, Vice Chairman ICOG, Professor Ashok Kumar, Dr. Sarita Bhalerao, Secretary ICOG, all the conveners, coordinators, chairpersons, and I thank particularly Dr. Suman Sinha for giving me this opportunity to talk on steps to be taken for prevention of wall prolapse. Friends, as you all know, that wall prolapse plays a major role in everyone's life. And we are really scared about wall prolapse everywhere. So what is more important when we talk about prevention, we give vaccination for preventing something. Similarly, in cases of prolapse, if we can prevent prolapse, nothing like it. If we can prevent wall prolapse at the time of surgery, nothing like it. So let's talk about wall prolapse prevention. What is the definition? Descent of vaginal vault below a 0.2 centimeter less than the total vaginal length above the plane of hymen. Next, please. Wall prolapse is the herniation of the pelvic organ or beyond the vaginal walls. It is reported to be the most common reason for hysterectomy in elderly. The number of women with pelvic organ prolapse who are managed without hospitalization and surgery and number of women with prolapse who never seek medical treatment is not known. This concept is very clear that nobody knows exactly what are the percentage. Next, please. You will find overall the percentage varies from 2 to 43%. In hysterectomized patients performed for prolapse, it is 11.6 and 1.8% for other benign diseases. That means more common following vaginal hysterectomy done in cases of prolapse. It can occur months, years after the hysterectomy with other pelvic floor defects such as cystocele, rectocele, enterocele, etc. Next, please. Let's try and understand what are the vaginal wall support. Maintenance of normal vaginal anatomy depends on interrelationship of intact pelvic floor, neuromuscular ligament and fascia. This complex relationship of vaginal support is perhaps least understood at the vaginal apex of vault. Without proper identification and correction of vaginal vault prolapse, surgical correction of other vaginal compartment is also likely to fail. Next, please. This Support contributes to 29.2% reoperation rate of women who undergo pelvic floor reconstruction. In a non-hysterectomized woman, the vault or apex is located posterior and superior to the cervix. After hysterectomy, the scar site assumes the position of vaginal apex or vault. Next, please. What are the relevant anatomy? The vaginal apex is the site at which multiple vaginal support structures converge. If the cervix is present, it serves as a strong attachment point for the ligament and fascia. A woman who has had a prior hysterectomy may not have a strong attachment point, leading to vault support weakness and potential prolapse. Next, please. 3 levels, we all know DLENS is 3-level support. Level 1 is support is composed of uterosacral cardinal ligament complex that originates at the cervix and upper vagina and inserts at the pelvic side wall and sacrum. This ligamentous complex suspends the uterus and upper vagina in its normal orientation. It helps maintain vaginal length and normal vaginal axis. Loss of level 1 support contributes to prolapse of the vaginal apex. Next, please. Level 2 support comprises the paravaginal attachment of full length of vagina and are suspended by the arcus tendinous fascia pelvis or lateral pelvic white line. Loss of level 2 support contributes to cystocele, etc. Next, please. Level 3 support is provided by perineal membrane, perineal body, superficial and deep perineal muscles. Next, please. As stated above, it is the level 1 support, that uterosacral cardinal ligament complex, that plays the most important role in maintaining vaginal wall support. The endopelvic fascia is the fibromuscular tissue layer that underlies the vaginal epithelium. This layer envelops the entire vaginal canal, extending from apex to perineum and arcus tendinous to arcus tendinous on the other side. Next, please. This diagram will give you full idea exactly about level 1, level 2 and level 3. If you look at level 1 support, if you understand this diagram, you will know everything about prolapses. The level 1 supports are basically ligaments. That means uterosacral ligament and cardinal ligament. Any defect of uterosacral and cardinal ligament will result into uterine prolapse, wall prolapse and enterocele. And generally they are asymptomatic or there is a bulge, nothing beyond that. If you look at level 2 support, these are fascias, whether it is anterior pubocervical fascia or posterior rectovaginal fascia. It will result into cystocele or rectocele. So basically patient will have urinary complaint and defecatory symptoms. If you look at level 3 supports, these are basically pubourethral ligaments and perineal bodies. These are sphincters. So it will result into hypermobility or enlarged genital hiatus. That will result into SUI, sexual dysfunction, vaginal looseness and flatus incontinence. If you can understand this diagram completely, you know what are the various levels of support and what all problems can occur. Next, please. So hence level 1, cervix long, cervix short are absent. Level 2, bladder symptoms and rectal symptoms. Level 3 is incontinence symptoms and sexual symptoms, basically because of problem with the sphincters. Next, please. What are the various symptoms with which the wall prolapse patient can come? Something coming out per vaginum is the commonest symptom. Pelvic pressure can be there, urinary and bowel issues can be there, and sexual dysfunction. Next, please. What are the predisposing factors which may be responsible for this? Primary pathology in uterovaginal prolapse. That means you forgot to do the things properly as was required. There is elongation of cervix, supravaginal or infravaginal. Cervix is unhealthy, hypertrophied or ulcerated, and necessary in procedentia as mentioned by Malpas. Peritoneal sac need to be closed. Pelvic diaphragm reconstitution. Small and atrophic uterus may be devascularized if left. Next, please. Wall prolapse basically occurs due to deficiency in anterior compartment, middle compartment, and posterior compartment. This can occur with intact uterus or after removal of uterus. In my talk, we will concentrate on prevention of wall prolapse following hysterectomy done either abdominally or vaginally. The incidence of wall prolapse following hysterectomy by any route practically remains same except in cases of prolapse. Further. Next. Role of sonography. Besides clinical examination, sonography is one of the major diagnostic procedures used in assessment of wall prolapse. You have to do a sonography with empty bladder and then fill the bladder gradually to study the mobility of wall descent. However, still it is in infantile stage. Next, please. Here you can see as per POPQ classification, you will find everything is out. Next, please. So how do you prevent? There are certain factors which are non-preventable, such as aging, you can't change the age, ethnic and racial factors, connective tissue disorders and neurological disorders, and estrogen lack as occurs in menopausal women. Next, please. What are the preventable factors? Obstetric factors like forceps-assisted vaginal delivery, prolonged second stage of labor causing nerve muscular damage of the pelvic floor, obesity, increased intra-abdominal pressure as in constipation, chronic cough, lifting heavy weights, multiparity, hysterectomy, wall prolapse can occur if proper care is not taken to support the vaginal vault and obliterate the Culday's sac. Meckel's scaldoplasty at the time of vaginal hysterectomy reduces post-hysterectomy wall prolapse. Suturing cardinal and uterosacral ligament to vaginal cuff at the time of vaginal and abdominal hysterectomy is one of the most important steps. And stop smoking. Next, please. Sacrospinous fixation to be considered at the time of vaginal hysterectomy in case of descent up to the introitus. This is after the hysterectomy has been done. How do you decide whether this patient is likely to develop wall prolapse later on or not? If you find that suture line has come right up to the introitus or just within the introitus, mind you, she is a patient who will develop wall prolapse post-operatively. Straight away go ahead with fixation like sacrospinous fixation of the vault at that time. Avoid subtotal hysterectomy. Uterosacral ligament suspension may be performed at the time of abdominal and laparoscopic hysterectomy, and sacrospinous ligament fixation and abdominal sacrocolpopexy are not recommended for preventing prolapse at the time of hysterectomy done in a case of non-prolapse related diseases. Next, please. What is more important is careful patient selection and counseling, high ligation of P pouch, repair of enterocele present, plication of Denon-Miller's fascia at apex, tying both uterosacral pedicle at the center, anchoring of the uterosacral pedicle to the vault, McCall's scaldoplasty, evaluation of pelvic floor strength, and Kegel's exercise. Mind you, Kegel's exercise is one of the most important things which we generally forget to advise to the patient. Kegel's exercise should always be advised to the patient post-operatively following any prolapse repair or following wall prolapse repair. Next, please. Let's talk a bit about enterocele. Defect of central compartment or apical defect can be present with pelvic organ prolapse, which is generally missed out. Commonest cause of wall prolapse or recurrence can occur de novo after burst repair, Purandare's cervicopexy, or neo-Gunter's pectopexy or pectohystopexy. Next, please. This is here you can see the enterocele. Next, please. Double helical suture or two separate sutures should be taken 2 finger breadth away from ischial spine with direction of needle medially. Confirm it is the ligament by a gentle tag. Sometimes when fix it with the, this is basically about sacrospinous ligament fixation. Next, please. Treatment of wall prolapse. What are the various vaginal procedures? Sacrospinous fixation, McCall's scaldoplasty, ileococcygeal fixation, uterosacral suspension, posterior vaginal slingoplasty, transvaginal mesh, and Lefauts colpoclysis. Next, please. Various abdominal procedures, whether you are doing laparotomy or laparoscopy, you should do colposacropexy or high uterosacral ligament suspension. Next, please. Hence, to summarize, wall prolapse is preventable with a comprehensive approach. Key elements are proper patient selection, correct surgical technique, and postoperative care. Collaboration between surgeon and patient ensures long-term pelvic health. Next, please. Thank you.
Thank you, sir. It was an excellent presentation.
Yes, very
We
nice.
needed time also.
And Dr. Rakhi and Dr.
Anil. Dr.
Anil,
Anil,
please,
comment.
please conclude. Then we will move to third session.
Sir, excellent presentation, sir. Dr.
Indeed,
Sarogi,
and
sir.
a treat to listen to you always. And you make the subject look very simple and very easy to understand also.
Madam, if you look at the chart will give you everything about the prolapse.
Yes, yes.
First one is ligament, second one is fascia, and third one is sphincter.
Yes.
These are the three main important things as far as supports of the uterus are concerned.
Yes. Thank you to the conveners, Dr. Kavita, Dr. Suman, and Dr. J.B. Sharma, sir, and all the coordinators also.
Thank
Dr. Rakhi, for being here for us.
Thank you
Pardon
so
me?
much. So now, Amina, please move on to
Yeah.
third session. Thank you,
Thank you
sir.
so
Thank
much,
you, Sarogi, sir, for joining and giving presentation such a simplified way.
Thank you, chairpersons and speakers of session 2. I request Sarogi sir to answer queries which are asked, sir,
Yeah, please.
about internal McCalls and external McCalls. And now we move on to the session 3. Thank you, Sarogi sir. And we have chairperson Dr. Kiran Pandey ma'am, who is the chairperson, Medical Education Committee, FOGSI, and professor, former HOD, Department of OB-GYN at Kanpur. Next. We have Dr. Pratik Tambe, sir, who's senior consultant, ART consultant, and gynec endoscopic surgeon at Ashirwad IVF Mumbai. And he has done international diploma in advanced laparoscopic surgery in France. Next. And we have Dr. Radhika AG, ma'am, who is the Honorary Secretary Associate of Obstetric and Gynec Society of Delhi 2023 to 24. Chairperson, LMC, Working Group, Guidelines International Network. Over to the chairpersons to take over the session and introduce the speakers of session 3, the last session for the day. Kiran Pandey, madam.
Ma'am, not joined yet.
Pratik Tambe, sir.
No, ma'am.
Radhika, ma'am.
No, ma'am.
Pratik Tambe sir has joined.
Nilima, can you just check if
Pratik sir,
the chairpersons have joined, because they had difficulty in joining. And Kavita madam has shared the link again.
Rights to unmute.
Pratik Tambe sir has a message. Please allow me to unmute. Can you please unmute Pratik Tambe sir?
Done, ma'am, done.
Okay, Pratik
Hi,
sir.
good evening,
Pratik Tambe sir.
everybody.
Welcome, sir.
I'm here. I'm here.
Welcome,
Good
sir.
evening, everybody. Thank you very much for inviting me, and congratulations to the conveners of this wonderful course on urogynecology. I think it is something which is a neglected specialty in India. I'd like to take this opportunity to thank the conveners and also the ICOG office bearers for having me here. Without further ado, I'd like to introduce the first speaker, Professor Dr. Geeta Mendirata. Her special interest, of course, is urogynecology, and she is the recipient of the Distinguished NBEMS Teacher Award 2024 from NAPL. She is also recipient of multiple awards for outstanding contribution in the field of medicine, APJ Abdul Kalam Award of 2022, chairperson of the Scientific Committee of NARCHI, chairperson Urogynecology Subcommittee of AOGD, multiple publications to her credit, and she has also served as the vice president of the ISOPAR Delhi chapter in the past. So over to Dr. Geeta Mendirata for her talk. And
Thank you, sir. Thank you, to Pratik, sir, for that kind words. Am I audible, sir?
Yes.
yes, ma'am, you're audible.
Yeah.
If you can share your screen and go full screen, please.
Can I request Nilima ji to
Yes. Yes, ma'am. Yes, ma'am.
hello?
Yes, ma'am, you are
Yes, ma'am.
audible.
One minute.
Can you just focus my slides?
Yes, ma'am.
So,
1 minute.
so I bring greetings from Sir Gangaram Hospital, New Delhi. And while the slides are getting ready, I'm going to be talking about, use of prolapse, pessaries in the pelvic organ prolapse, which is a very neglected feature, I think, of prolapse management, and it is yet a very, very rewarding for certain patients in certain circumstances. So, the general principle which I will bring out once they are getting my slides on, I would just like to start that basic mechanism of action, as the previous speakers have said, it is basically used to provide support to the vaginal hernial defect. There's a hernia there, so it provides support to that defect. It includes the anterior, posterior, and apical and combined sites. Next slide, please. I'll have to ask you to move. So now the basically mechanism of action, as I've told you in prolapse, is it provides support to the hernial defect. And in cases of stress urinary incontinence, it is related to the improved urethral function, wherein it has been shown to increase the functional urethral length, and it increases the urethral closure pressure also. And to some studies have also said it helps in the resolution of detrusor instability. And it also reduces the Q-tip angle, as the Pragya ji has already told you about, more than 30 degrees. The pessary also helps in that. Next slide, please. Now coming to efficacy of pessary for prolapse and SUI, they are usually first-line therapies for symptomatic prolapse and SUI that should be discussed with all patients. And this is my main message, that please have knowledge about this issue and discuss with the patient, because many meta-analyses, atlas studies, etc. have proven that there is an objective benefit with pessary treatment for both prolapse and SUI. Next slide, please. Now, in two studies, they said in more than 65 years of age women, it was seen that they were more likely to use a pessary for more than a year compared to when we put the pessary for women less than 65 years. Next slide, please. Next slide, please. Now, pelvic floor muscle training, and Sarogi sir has already said, is also very important. And though it requires time and they have no adverse effects, but use of pessary and exercise is a win-win situation for all of us. Next slide, please. So the ATLAS study was the ambulatory treatment for leakage associated with SUI, and that has distinctly proven that when you use pessary versus behavioral therapy versus both pessary and behavioral, it was much more useful. Fewer women in the pessary treatment versus the behavioral treatment reported a complete absence of bothersome incontinence symptoms. Next slide, please. Now, coming to what are the clinical scenarios where a doctor will use. Basically, a patient prefers a non-surgical treatment. Presence of severe medical comorbidities, obese, cardiac patients on blood thinners who are not fit for surgery, poor surgical candidates, or sometimes women want to delay surgery for personal reasons for some weeks, or patient has a recurrent pelvic organ prolapse or SUI, and she prefers to avoid a repeat surgery who's already had. However, it must be told here that prior prolapse or incontinence surgery are risk factors for failure to fit a pessary and a failure to get the response which is usually seen with a de novo patient. Next slide. So also in cases patients is waiting for a prolapse repair and she has vaginal ulcerations because of an neglected prolapse. So you need time to heal with estrogen, you need time to heal the ulcer, so you can put a pessary. Also, if a woman is pregnant and has a prolapse, so this to tide over the pregnancy period, she can be fitted with the pessary because she wants further children sometimes. Then the benefit of surgical repair of POP, like a Manchester, as madam said, you can offer a prolapse in case she's not willing for a Manchester, you can fit it till she has finished her subsequent childbirth. And also when she has a voiding dysfunction related to prolapse and doesn't want a surgery. Next slide, please. Now, what are the contraindications? What are the scenarios where you will not use a pessary? So any local infection, like a candida, trichomonas, bacterial vaginosis, which means you have to do a pap smear before you decide, or she already has a neglected copperty or an exposed foreign body, or she's latex sensitive, though most of the pessaries now are silicone, but there are certain pessaries which are latex.
If she has a latex sensitivity, you cannot. Then non-compliance. Certain pessaries require changing every 2 nights or 3 nights. So if she's a non-compliant, she will not be a candidate. Or a sexually active woman who is unable to remove and reinsert the pessary herself. Next slide. So our approach basically is to evaluate the patient, take a good history, understand the patient's bothersome symptoms, understand her concerns, her goals and activity limitations, do a physical examination, the POPQ scoring, any SUI or occult incontinence, see the anatomy, is the gaping introitus is there, or introitus is all right, but the upper part is gaping, it's a level 1 defect. That will help you to choose the pessary. Is there an associated urinary incontinence or a voiding difficulty or a UTI, or if she has an overactive bladder? You have to treat the UTI and overactive bladder. Then if she has any defecation difficulty, fecal incontinence or constipation and bulge, etc. And how much is the bulge? What is the heaviness? What is the discomfort? Once you have a global 360 degrees view, then you start applying your pessary knowledge and fit it as per the patient's requirement. Next. So guide towards is basically, in general, we know the support pessaries are used for women with maybe stage 2, stage 3 POPQ, and the space filling pessaries are used for women with advanced like a stage 3 or 4 prolapse. Next slide. Next slide, please. So so most of the pessaries, as I told you, are made of silicone, but some of them are made of latex. So detailed description of the types are, broadly speaking, there are support pessaries, there are space filling pessaries, and there are incontinence pessaries. So support pessaries, the commonly used are the ring pessary. Lats and lever and gerung are not so commonly used. Space filling are used for higher degree of prolapses, and usually they are gallon or donut and sometimes cube pessaries. Incontinence, the commonly used ones are the incontinence ring and dish, or an impressio device, or a ring with a, you can say, with a little knob. Next slide, please. Now, this is the box which we have from the Coopers, where we have a fitting. All of the pessaries are, you can see there, and we fit the patient. We wash it nicely and fit the patient. You see on your left the ring with the knob. On top left is your gerung, your gallon, and the cube pessaries. The one on the middle, upper one are the donut, and the right are the ring without the knob. Next slide, please. So, see, as I told you, how we change. Next slide. So this is the battery of pessaries we have. Next slide. Next slide. Next. So now this is the ring pessary, folding pessary. Now this is used, this ring pessary, which is without a support. You see the center part is empty. This is useful in younger women as they have less atrophy of the levator and a more oval contour of the vagina. And since this does not have a diaphragm, so this allows to take the shape of the vagina into the oval shape. And additionally, it's very easy to insert. It will fit approximately 70% of the patients. It's very easy to insert, remove, and it can be done with the patient only. And it can allow intercourse. As you can see in the diagram on the left, it's easy for intercourse while in place. It can be done. Change it once in 4 months. Just fold it and insert it, and then rotate it, and then it's there. And of course, you have to check if there are abrasions or anything. You can apply estrogen cream and then call the patient after a week or so. Next slide. Now, the ring without, next slide. Next slide. Next slide. Now, this is the ring, the previous one, please. Now, this is the ring with the support. As you said, there was a no support in the previous one. This is ring with the support. And there is a little challenge with the intercourse in these cases. Next slide, please. This is the ring with support and the knob, which is a folding one. Now, this can be utilized in a patient who has SUI along with prolapse, as seen in the next. You can see in the lower panel, the knob sits just at the uretrovesical angle, and that helps in the prevention of urinary incontinence, whereas the top one is sitting just at the supporting the level 1 defect in a prolapse. Next slide, please. Next slide. So this is the gallon, and as you can see, I'm holding it like with the top, it's like a letter K. So now the gallon is a space filling. I told you it is a space filling pessary, and they are basically three-dimensional, and they differ from the support pessaries in that they have a very large base and which supports the apex. And gallon is one, donut I'll show you, inflator ball, all these are space filling and they are used for higher degrees, 3 or 4 pelvic organ prolapse, and especially post-hysterectomy vaginal wall prolapse. But they have no use in SUI counts, treatment of SUI. A problem with space filling is that they are difficult for the patients to remove, number one, and sexual intercourse is not possible when they are in situ. And this pessary, you have to just fold it, insert it, and like a screwdriver motion, you can put it so that the circular base fits on the cervix and the stem. Next slide, please. Yeah, so the stem, as you can see, is in the long axis of the vagina, and the flat one is like a suction. It provides support to the apex in a wall prolapse and to the cervix in case this is in situ. And there are small holes, as you can see, in the base to allow the secretions to drain out. And they are usually available in 1.5 to 3.5 inch sizes in 1/4 inch increments. So most women can be managed with 2.5 and 2.7. And the advantage of these space filling pessaries is that they, as I said, large prolapses, they reduce the rectoceles and related symptoms. And patients with a very wide genital hiatus, the level 3 defects, they are very useful for these patients. Next slide. Next slide. Next. Now this is the donut again. Donut fitted there. Yeah, next slide. Sure. Again, the various sizes are seen, and this is how you can just give a donut for a 3rd degree prolapse. Next slide. Next slide. These are the cubes, the 4 cubes, and you can see the suction devices there. You squeeze these cubes and then you insert it. And sometimes, next slide, next. You can see the tandem cube on your left side. For the big prolapses, you can use tandem cubes. That is, you have a bigger cube and a smaller cube inside, one behind the other. And this helps in the bigger prolapses. Next slide. Next slide. Now, if the initial pessary is not successful, you have to basically go back to the size assessment, put a bigger size if the previous one falls out, or if she's uncomfortable, give the smaller size. Coming to the trial, in case of pelvic organ prolapse, if gallon is not successful, next try is always try gallon first, then the donut. And in SUI, always try the ring with the knob, and that is very useful. Next slide. Now, prolapse outcomes are very encouraging. 70 to 90% patients reported urinary symptoms, bowel symptoms, sexual function improvements. Next slide. Now, this is a very interesting thing, the non-symptom related outcomes of pessary use. When I was finding this, preparing this, I found that there is a limited data that there is a decrease in the size of the genital hiatus after 3 months of pessary use from 4.8 centimeters to 3.9 centimeters. And also the prolapse degree decreased from 3 to 2. Hydronephrosis improved because probably the uterus lifted up and the ureter kinking was less. So it was a very good positive thing which they found. Next slide. So short-term effect, next slide. There are various short-term, long-term observational studies. I don't bore you, but in a nutshell, they are very useful for, pessaries. They have all reported very good results. Next slide. So this is the inflator ball again. This is a space filling. Next slide. Next slide. Even the spherical pessary. Gerung, next slide. These are just to show, complete the picture for PGs. Basically, it is a U-shaped flexible ring with a rubber diaphragm, and the two bases sit on the posterior vaginal wall. Concave surface and diaphragm support the anterior vagina. Next slide. Now the Schatz is another support pessary, as you can see, like the ring. Next slide. Lever pessary. Next slide. Next slide. Now, this is what I found in the net. They are these custom made. Actually, they are 3D printed. Interestingly, they are 3D printed, custom made pessary, the Ria pessaries and these custom made pessaries, the ring with a dish, ring with a knob and cube. Next slide, please. Next slide. And incontinence pessary, I've already explained. Next slide. Next slide. The ring with the dish. Next slide. Now, the last slide is the complications. They can be erosions, they can be bleeding, extrusion, discomfort, vaginal discharge with a neglected, like a cube, which has to be changed every 2-3 days. They have the problem of discharge, pain, constipation, again, due to poorly fitting, poorly chosen pessaries, and impaction. And rare cases of rectovaginal fistula have also been reported. Thank you.
Thank you very much, Dr. Geeta Mendiratha. That was a fantastic talk on various different kinds of pessaries. I'm sure it's an eye-opener talk for all of us. Thank you very much. And I think we'll move to the next session since we're already running late.
Thank you, sir.
Can I request one of the other chairpersons to introduce our next speaker, please?
Sir, I don't find any other chairperson. Please introduce another speaker.
Radhika ma'am is there.
I'll take care of it. I'll take care of it. I'll
Yes,
introduce
sir.
Dr. Achla Batra.
Okay.
So Dr. Achla Batra is well known to all of us. She's a governing council member of ICOG. She's a past president of NARCHI. She's an ex-professor at Safdarjung, 40 years of experience, multiple awards and accreditations to her credit, multiple guidelines as well from the MOHFW that she's contributed to. And she's going to be speaking to us on yet another important topic in urogynecology, and that's specifically the sling surgeries for the management of nulliparous prolapse. Over to you, ma'am.
Thank you, Pratik, and thank you, Kavita, for making me part of this wonderful program. Can I share my slides?
Yes, ma'am, please go ahead.
Yes,
Yeah.
sure.
So, are my slides visible?
Yes, ma'am, you can go full screen, please.
I'm trying to do that.
Slideshow from beginning.
Madam, slideshow since beginning.
Slideshow at the top and then from beginning.
Yeah.
Yeah, current slideshow.
Yeah, thank you. Thank you so much. So I'm going to talk about something which everybody doesn't do. Though the most important thing is that Indians have the most incidence of nulliparous prolapse, and mostly nearly all surgeries have been devised by a great Indian gynecologist, but because there have not been many publications, that's why it's not mentioned in the international literature much. We have 60 years back, Dr. Shirodkar gave us the Shirodkar sling. Then 65 for Andhra Psychopexy, Khanna sling in 72, Sonawala 78, Joshi 1993, Virkut composite in 99. So all Indians, great Indians. What is the principle of sling surgeries? Basically, nulliparous prolapse is not always in the nulliparous. Basically, the ligaments, the supports are weak. If you examine these patients, their levator tone would be good, but their basic ligaments are weak because of inherent weakness or because of some nerve injury or maybe some spinal cord defect. Whatever it is, the supports are weak. So what is done in sling surgery is that you are reinforcing the strengthening the pericervical ring by attaching either fascia or rectus sheath or synthetic sling from the cervix to some fixed structures like sacrum or symphysis pubis or anterior superior iliac spinal in a dynamic sling to the rectus sheath. It helps in preserving uterus and fertility in a young patient. They have been classified by Dr. Virked into, according to the loop they form into closed and dynamic or static. So Shirodkar, the best anatomical sling operation The support is anterior longitudinal ligament attaching the sling to the cervix. It forms a closed loop and it is static. Coronary rectus abdominis sling is attached to the cervix. Worked composite combines the two. Dr. Sonawala thinking that on the left side we have the sigmoid which gets pressed by the sling, so he made an open sling on the right side. Dr. Khanna made a sling from the posterior part of the cervix to anterior superior iliac spine. Joshi is being mostly used for vault, but can also be used for nulliparous prolapse, attaches the anterior cervix to pectineal ligament. All of them are static sling except for Kurandere, which is a dynamic sling. So, who should undergo? Naturally, a young woman with second or third degree prolapse, uterocervical length of less than 5 inches. Mostly, they don't have a cysto or rectocele, but if they have, they can be repaired from below. All these surgeries are abdominal surgeries. They're not suitable for hypertrophied, lacerated, and infected cells. Dr. Shirodkar was the first to describe the conservative sling operation. As you can see here, the sling is attached from the posterior part of the cervix to the anterior superior iliac spine going retroperitoneally. And because there is a sigmoid colon on the right side, left side, so there is a psoas muscle, they form a loop through which the sling goes so that the sigmoid is not pressed. You require, if you don't have these, you can use large round body needle, but he had also made Shirodkar needles, and of course there is this uterine clamp. So abdomen is opened at the level of the anterior superior iliac spine, then you bear the sacral promontory. Then the sling, Marcelin tape, is attached to the posterior part of the cervix at the isthmus at the level of the uterosacrals. You make an incision over the psoas muscle to form a small ring with the Marcelin tape between 2/3 and 1/3. And then you take the Shirodkar needle from behind the isthmus. You have to take the tape. So you go from lateral to medial, take the tape there. I'll just show you a video. And into the eye of the needle, the tape is put and it is brought out. Then you bring it out through the psoas muscle ring. And then retroperitoneal, the section of the peritoneum from the sacral promontory till the level of the cervix. And then pass this Shirodkar needle from the promontory to where the sling is, and again needle, the sling is put in the needle and brought to sacral promontory. Right side is easy because there's nothing much dangerous there. So you straight away dissect the peritoneum, put the needle from promontory till the level of isthmus and bring the sling there. So as you can see in this video, we are fixing the center of the Marcelin tape with linen or silk. We use mostly silk. Then we attach it to the back of the cervix at the isthmus at the level of the uterosacral. After having done that, we will make a incision over the psoas muscles, peritoneum, and make a loop. So you will see now a loop would be made, and that loop is being made, and this loop will be used to pass the Marcelin tape when we are going from the. So you can see the loop. So like I showed you, we have going through the loop, then to the promontory. So in this, you can see that after we have put in the Marcelin tape into the Shirodkar needle, then it will pass through the loop which we had made. And then after passing it through the loop, we have dissected the peritoneum, and then again the needle will pass. Now we are passing it through the loop. And then needle will pass from the sacral promontory to this place to catch hold of this Marcelin tape. So here again, we are passing this needle, and again it is being threaded. Marcelin tape is being threaded and it is being brought to the promontory. So similarly, it is done on the other side, then it is fixed at the level of the promontory. Either you can make a bed, or you can, after making the bed, tie it over the slings and then also stitch the slings down to the anterior longitudinal ligament. This is the most anatomically correct procedure. It provides a strong static support, and of course, there is no decreased tendency for androcele formation also. There have been studies following the Shirodkar abdominal sling operations, and patients have found to become pregnant in almost 70% of the cases, and they can deliver vaginally. And only one complication was seen in this study, and the recurrence rate was also only 8.69%. Another study was done. They found 41.3% conceptions, and out of these 24 patients, 90 delivered vaginally. So it is a good operation. The only thing is that one has to learn it. It is slightly difficult to perform. We have done it in our times. I don't know if people now, students now have ever even seen it. There is a risk of injury to circle veins, hematoma formation, damage to external iliac vessel, ureter, colon, nerve trunks, and risk of bowel obstruction. But you have to know your anatomy well to perform this operation. Then we have Purandare cervicopexy. It's a closed loop anterior sling operation. Again, the slings are formed from the rectus sheath. Initially, they were formed. We have done lots and lots of slings with rectus sheath, and still we get patients who are not, prolapsed after 20 years also. And it's a dynamic sling because when the patient comes, the cervix comes up and as the rectus sheath contracts. Just a minute. Okay, and probably this is not working. So so what we do is we take a phalansteal incision and open the abdomen, and then before opening the rectus sheath, we give a small 1 centimeter longitudinal incision and then separate the rectus sheath from the muscles and make a sling of about 4 to 5 centimeter length and 1 to 1.5 centimeter width. And this sling is then
We can't hear, madam.
Madam, we can't hear and we cannot see.
Audio
also.
is not there.
Even video is not there.
Yes,
think she's
madam has
trying to
closed
fix
the
it.
presentation.
So I think
I
if
think
the
she's
time is, whether time is left or not.
Time 1 minute 59 seconds is there, madam.
Okay. No, so I think she is going to conclude.
Yeah.
Almost done.
Yeah. Then we have, I don't know what happened. Can you hear me?
Yes, now we can hear you, madam.
We can't see the slides. The PPT is not visible to us.
I think you can just summarize the video.
Yeah. So
rather than
what
trying
is
to
that
play it.
we have what we have done is that made the sling, and then you open the uterocycle pouch, take a round ligament forceps, go from the uterocycle pouch along the round ligament and open it outside the rectus muscle into the internal inguinal ring. Pick up those two slings we had made and bring them to the isthmus and then tie them to the isthmus and the uterus is lifted up. And then we also have this Sonawala sling. Like I said, it is the same as the Shirodkar, but on the right side where there's no sigmoid. So just from the isthmus to the sacral promontory. Then we have Joshi sling, which is from the anterior part of the cervix to the pectineal ligament. And then we have Khanna sling from the posterior part of the cervix and between the leaves of the broad ligament to the anterior superior iliac spine, but there is the danger of periostitis. And whenever we are doing one-sided sling, like in Zonawala, we will, of course, placate the round ligament. And there is a danger of enterocele formation when we have these anterior slings like Purandare. So it's a good idea to do Moskowitz. Now people have, changed from the rectus sheath to Marcellin. Yeah.
சொல்லுங்க yeah
From to Marcellin tape. So instead of
ஐயோ
rectus
ஒண்ணும் இல்ல
sheath,
நீங்க
you can
செக்
even
பண்ணிருங்க அது
Marcellin tape, and similarly you attach the Marcellin tape to the promontory and bring it retroperitoneally to the isthmus and uh, do the Purandare without using the. For the Purandare, you take the Marcellin tape, attach it to the cervix, and then you pass the round ligament forceps from lateral to medium through the internal inguinal ring and pull these tapes from the isthmus outside the rectus muscle and then stitch it to the external oblique. So it will again form a dynamic sling and you don't have to use rectus sheath. Then Dr. Varkud has combined the Purandare for the left side and Shirodkar for the right side to make a dynamic sling, which is, serving the purpose of a dynamic sling and also having less complications. So it is a good idea to learn these procedures. Maybe we'll come up with more modifications to this, but these have been, devised by our Indian gynecologists and have been found to be good, but not much literature is there about that. Thank you.
Thank you very much, Dr. Ashla Batra, ma'am, for explaining all the different types of sling surgeries. Some of these we've seen being done by our seniors. Many of these are gradually dying out. It's a lost art. We need to carry these out and train our juniors as well so that these are not lost. Because in Western countries, these are hardly ever done. These are actually India's gift to OBGYN. Thank you very much for the wonderful lecture. I wish some of the videos had played. There are some queries for you in the chat box. Maybe you can take them in the chat box itself.
Yeah.
We'll move to the last speaker of the day, and we have a distinguished international faculty, Dr. Baburam Dikshit, who is going to speak to us on surgical management of anterior compartment defect, the tips and tricks. Sir is an associate professor of OBGYN at Dharan, and he has multiple affiliations in Nepal. So over to our distinguished international faculty.
Thank you. Thank you, organizers. And I would like to thank the organizers and the for providing me the opportunity for this presentation. And I would like to thank my teachers, Dr. Mohan Chandra Regmi in Nepal and Dr. Amita Jain and Aparna Hegde from India. I'll slide. Okay. Can someone please
can I share
my
sir?
slide? I have given it
Yes,
to the
sir.
organizers.
Yes, sir.
Yeah.
Sir, you are
Good
muted.
evening, everyone. I would like to thank again. Am I audible?
Yes.
Yes, sir, we can hear you.
I have nothing to disclose. I'm talking about the anterior compartment prolapse defect repair. Before going to the presentation, I would like to say that I have two small videos in the end regarding the anterior compartment prolapse repair. Anterior compartment defect, it is descent of the bladder or urethra or both. Recent ICS Ayuga Joint Committee has advised to use the anterior descent rather than the cystocele, because we don't know whether that contains bladder only or urethra or both. It is one of the most common pelvic organ prolapse and the most common segment to fail after the surgical correction of the pelvic organ prolapse. And patient presents with the most common symptom is the bulging sensation or pressure in the vagina. Urinary symptoms like urgency, urinary incontinence, frequency, stress urinary incontinence, and all sort of the voiding disorders may present with the recurrent UTIs, pain or discomfort during sexual intercourse. Next slide, please. Coming to the pathophysiology, anterior vaginal wall is one of the complex plate. Mid vagina is attached to the arcus sternus fascia pelvis. Lower vagina is attached to the endopelvic fascia, mostly the pubocervical fascia. There are different terms for the anterior vaginal wall descent. Some call it as distension cystocele, some call it as displacement cystocele. There are different type of defects: transfer defects, midline defects, lateral defects, and usually the most common one is the distension cystocele, which is present in the most common risk factor for the distension cystocele is the pregnancy and childbirth, and displacement cystocele, that is pathological defect of connection of the vagina with the arcus sternus fascia pelvis. Usually the anterior vaginal wall defect
Kavita ma'am?
Yes.
Sir,
Yes.
sir, internet is not working.
Okay. Dr. Baburam.
Not audible, clear.
Okay, so anybody can read. Dr. Baburam, you are not able to speak because there may be network issues. Hello? So anybody can take. Should I speak? You will share the slides? Dr. Baburam, are you able
Yes,
to?
madam.
Yeah. So
Am I audible now?
Yeah, now
Sorry
you're
for
audible.
that.
Yeah.
If I am not audible, please share my videos, which is in the last. Okay.
No, it's audible.
Diagnosis
Speak
mainly.
loud. Please speak
Yeah.
loudly.
Okay, ma'am. Diagnosis is mainly clinical. We need very investigations like analysis. Pelvic ultrasound usually is not indicated. Occult SUI should always be checked because
Still not working.
you might
Sir, internet
problem
is unstable, I think, sir. Baburam,
surgery,
sir.
which might get
Sir?
she might have stress urinary incontinence because of the usually urodynamics is not indicated. Plus, whether okay, yes, yes, madam.
Okay, sir. Now okay. Internet was little unstable, sir.
Go ahead, Dr. Baburam. There are some problem in
Okay.
Nepal.
Okay. Main indication for surgical repair is to relieve symptoms and improve the quality of the life. And you have to keep in mind that anterior vaginal wall prolapse repair associated with the failure rate of more than 10%, anatomically more than 5% symptomatically, and at least 1% of the patient need resurgery after the 2 years. Next slide, please. There are many surgical options for anterior vaginal descent. There are controversy regarding the use of mesh in the anterior vaginal wall prolapse repair. But there are different studies which compares native tissue repair with the mesh augmented repair. And there are different answers, questions to be answered in anterior vaginal wall prolapse repair. Is there any role of apical support during anterior vaginal wall repair? And vice versa, because usually in the patient with apical prolapse, we need to do anterior vaginal wall prolapse repair very carefully, because it is associated with more than 20% of the failure after the apical prolapse repair is anterior vaginal wall prolapse. So, is there any role of apical support during anterior vaginal wall prolapse repair as well? It needs to be answered. And role of concomitant sling surgery during the anterior vaginal wall prolapse surgery is also controversial, because there are a lot of trials going on whether we should concomitantly undergo sling surgery with the anterior vaginal prolapse.
Can it got lost now?
Yes, ma'am.
Sir, not audible, sir.
Due to disturbance in Nepal, I think.
Yeah, it's very much disturbed. So I think for angiocolporaphy, we all do. We need placation of vaginal muscularis and adventitia overlying the bladder, that is pure cervical vasa. It can be done with, I think, Vicryl or even Prolene 10 and placate and deattach the paravaginal tissue in such a way to reduce the protrusion of the bladder and vagina. So we all do angiocolporaphy. Many times it is combined with a vaginectomy, but even hysterectomy not done, but only there is anterior compartment defect, we can go for ACR, where we just do buttressing of the bladder along with the tightening of the cervical vasa. So that is very helpful, and I personally do, if there is a large cystocele, then I do with the Prolene 10, and it works a lot. Only thing in Prolene is there may be not, and it sometimes it causes problem to the patient. So next, Baburam, you can join. And many modifications have been done. So it depends on how lateral resection is carried out, where sutures are placed, type of sutures which are used. So these are the different types of sutures, rollografts, like cervical ligament attachment, site-specific fascial repair, anti-prolapse repair with the grafts with the cystocele large and it's not getting cured even after simple surgery with a ACR, then graft can be used if it fails with the Prolene or Vicryl. And sometimes there is paravaginal defect also, which should be taken care of, which is by the side of the urethra. It can be stitched on both sides of the urethra. The stitch is taken and it's been tightened. It helps in reducing SOI also. So these are tips and tricks. Next. So this is, I think this is video. You can run the
Video
video.
can be showed. They can show the video.
You just show the video.
Our support team can show the video if they have it.
Ma'am, video is not there.
It's not there.
No,
Yes, ma'am. Yes,
the
ma'am.
video.
Yes, ma'am. Yes, ma'am.
There is video.
They said he said he has to video in the end.
Just make it full screen.
It is full screen only. nahi aayega.
Yes, ma'am.
First of all, identification of your cervical fascia is met after dissection of the intervaginal wall.
Audio is not there. Video.
Is there any sound? Audio?
No, no sound, ma'am.
Okay.
Stop then.
It's full.
So it is a native tissue repair wherein they are taking the pubovesicocervical fascia. There is a question in the chat box regarding transverse defect. The transverse defect is detachment of the pubovesicocervical fascia from its insertion, that is a pericervical ring. So transverse defect can be repaired by attachment of the pubovesicocervical fascia to the pericervical ring, thereby attaining the anatomical attachment back. So here they are taking bites on the fascia, the pubovesicocervical fascia, which will be white in color. They are taking concentric bites on the pubovesicocervical fascia. And they are tied in the center. Usually they are absorbable sutures like 10 vicryl or 20 vicryl over the fascia. Pericervical ring. Renu Jain has asked a question. Pericervical ring is where the fascia, that is the pubovesicocervical junction, where the bladder ends and the cervix starts. That is where the pericervical ring is there. There is a question. Does site-specific facial repair for distension type of cystocele, does it still hold true, or the traditional anterior colporrhaphy is enough? So it is basically the site-specific repair. We need to identify where exactly is the defect, whether it is a distension cystocele or a displacement cystocele, transverse defect, whether there is a lateral defect. So we need to attach the fascia by identifying where it is detached. That we do by opening the sponge holder and reducing the mass and asking the patient to strain. With the open sponge holder, if there is a bulge in the center, it is called the central cystocele or the distension cystocele, wherein the ruga will also be absent. In a displacement cystocele, we can see after we usually close the sponge holder and keep in the center, there will be a detached fascia from the lateral attachment causing a lateral bulge. Here again, it is very difficult to repair a lateral cystocele, where it is called the lateral paravaginal defect repair, wherein we need to attach the fascia to the lateral structure, that is the arcus tendinous fascia pelvis.
And this will after this doing fascial repair, we will do the vaginal stitching. So vaginal wall is stitched. It will be clean. So either interrupted, mostly interrupted, sometimes continuous. So I think all the 3 sessions have been done. So Pratik sir is there. He can conclude, or we can go for the directly question. So just we request support team to share the questions, and they will explain the time.
So I'd just like to take a moment to thank everybody for including me in this prestigious course of ICOG for the urogynecology. I'd like to also congratulate the conveners for the course, Dr. Kavita Barnwal, Dr. Suman Sinha, and Dr. J.B. Sharma. Thank you to the ICOG office bearers for this opportunity.
Thank you, sir. Thank you for being with us.
Thank you, sir.
We had some difficulty, especially in these 2 sessions. There was some network issue, but anyway, we could complete. So now, just requesting ICOG team to share the link for the questions.
Ma'am, link will be sent in the chat box.
Okay. So now how much time? 10 minutes?
15
Yes,
minutes.
ma'am.
Okay.
15 minutes.
Okay, okay.
Hello, madam.
Yes.
Thank you, madam. Nilima, how much time is left?
Ma'am, 6 minutes.
Actually, we are able to get the scores as well. In the 14th question alone, there is um, some more to be added in that. What is the stage of prolapse? 14th question.
मैम अभी अपन आंसर बताएंगे ना?
Yeah, we'll tell the answer, but there is some more to add in that. POPQ is missing.
Just you read the answers fast, Meena. Then I will conclude in 1 minute, okay? We are already very much late.
Actually, after submitting, they we are getting the score as well as the correct answers, madam. In this.
Yes, yes. I think by the time I can conclude. Shreya? Nilima?
Yes, ma'am.
Can I conclude by the time?
Ma'am, 4 minutes is left.
Okay.
They're asking if they can exit, but let them be, so that they can see the correct answer. Meena? Yes.
Yes, actually, answers are coming, ma'am. Once we submit the
I know, but
response.
the participants asking that if they can leave. So I wanted to tell them that stay there so that you can know the answer.
Yeah, they have to stay.
So please write in the group that kindly stay till the answers are declared. Questions are very nice.
Is the time over, Shreya?
Ma'am, 39 seconds.
Because most of them have checked the answers and they're leaving.
Well, answers have come, madam. Answers came itself after submitting. Acha. Okay,
Yeah.
okay. Then they can leave. They can leave.
They have all checked the answers, madam.
They have checked because once you submit,
It
the
is
answers
coming
are
with
there.
the score as well.
Acha.
Sarita madam is joined.
Okay, for the conclusion.
Ma'am, can I share the answers?
Yes.
Yes.
So, Meena, you have to read out.
Yes, ma'am. Are you sharing the answers?
Yes, yes, yes.
ma'am.
Yeah. I'm not able to see actually. Just a minute.
Answer to one is D.
Screen.
Can you see Meena?
Recording in progress.
Shall I read the answers, madam?
Ma'am, you are logged in 2 devices. The echo is coming.
Now, is it okay?
Yes, ma'am.
So, all is true for tethered vaginal syndrome except. Answer is, it is always associated with stress urinary incontinence. Anything comes with always or never will not be the answer. So, tethered vaginal syndrome is D, which is not principle of pelvic floor surgery. It's a negative answer. So, remove excess vaginal tissue for tight hemostatic repair. That is the answer. What is not true for concertina technique? Ligaments are reinforced. So, that is the answer. In 4, women with prior hysterectomy had higher prolapse and pelvic symptoms after the menopause. So, they have not asked why not C in 2. So, the 4th is answered 4, D. Which type of pessary is most commonly used for first and second degree uterine prolapse is ring pessary. Most common POP in female is the anterior vaginal wall descent. Which pessary is most suitable for women with stress urinary incontinence is ring pessary with support. All measurements in POPQ classification system are made in dorsal position except that is by straining or valsalva except total vaginal length. That is true. Loss of rugae in anterior vaginal wall is common in distension cystocele. That is a central cystocele. Point AP and BP denotes posterior compartment. Ischial spine is inferior to the intermediate portion of the uterosacral ligament, but variably position landmark within the ligament's width. And which best describes the anatomical organization of neurovascular structures within the cardinal ligament relevant to surgical dissection. That is, it can be divided into anterior vascular portion and a posterior neural portion, and the deep uterine vein serves as a landmark between them. And which bedside test is most useful to assess the levator and muscle strength during POP evaluation is Oxford grading of pelvic floor contraction or vaginal palpation. What is the stage of prolapse? Here, actually, the POPQ grid is missing. What was given was stage 3. And 15 is factors having strongest association with stress incontinence on transperineal ultrasound is bladder neck descent and urethral rotation. Does transperineal ultrasound has any role in detection of anal trauma? It is yes. Next is all the following indications for Fothergill's procedure except that is endometrial hyperplasia. If there is endometrial hyperplasia, high risk for atypia and malignancy. So we generally do a hysterectomy, not a Fothergill's. Dilatation curettage is done as first step of Fothergill's procedure for the following reasons except. So except is termination of pregnancy. The gold standard treatment for all prolapses, sacrospinous fixation. And colpoclysis is most suitable for elderly women not desiring sexual activity. Yeah, so 14th question we'll consider because it is not a complete question.
Agreed.
I'd like to request Kavita madam to give the concluding remarks. With this, we can close the session, madam.
Just yeah. Kavita, kindly
Unmute, yeah. So thank you so much. Thank you, Meena. So all the three sessions were very informative and academic. The speakers, Dr. Survi, Dr. Karishma, Dr. Pragya, well explained anatomy of the pelvis perineum, pelvic floor disorders, and transperineal ultrasonography in management urogynecological disorders. And I'm thankful to all the three chairpersons, Dr. Anju Soni ma'am, Dr. Ashara madam, Dr. Renu Gupta. And for the second session, it was very long. 4 speakers were there. Dr. Gurneet Singh spoke on principles of pelvic surgery. Suman madam on POPQ classification, practical application and limitations, very nicely well explained. And Dr. Srikala madam explained on Fothergill's operation, also showed very nice video. And Saravgi sir, as usual, explained so well in simplified way how to prevent the cord prolapse. And the chairpersons, all the Dr. Anil Sakari and Dr. Rakhi Singh, I'm thankful to them for putting their inputs and concluding. For third session, Mali chairperson Dr. Pradeep Tambe sir was there. So I'm thankful to him. My heartfelt thanks to Dr. Pradeep Tambe sir who stood till last. And the speakers were Dr. Geeta Medirata who speaks so well about the choosing the pastries. We were not aware about so many pastries. So she has very well explained. Sling operation that was by Ashla Batra madam. She also showed video, though there was some disturbance, but we could understand. And Dr. Baburam Dikshit tried his best, but since there is network issue in Nepal, we all know there are lots of disturbances. So he couldn't complete, but Dr. Meena and the support team helped, and the video could be seen by all of us. So I'm thankful to the outset. I'm thankful to all the office bearers of Foxy, chairperson, ICOG, Sarita Valera, madam secretary, and vice chairperson, and the coordinator, especially Dr. Meena, who did so much work and stood till last. And last but not the least, I'm thankful to ICOG's support team, Dr. Nilima and Dr. Shreya, who are doing so much work and helping us. So thanks a lot. And today's first session has been completed, and still we have to go for 2 more days. Thank you and good night.
Thank you, Kavita ma'am, Suman ma'am, for the wonderful opportunity given. And thank all the chairpersons and speakers for their wonderful academic contribution. And all the delegates without whom the whole
my heartfelt
program
thanks
would
to
not have
delegates
been
also.
successful.
My heartfelt thanks to delegates because they had registered in large numbers, about 500 were there, but they had set only for 300. So later on they did some technical work.
Yeah, because they were not allowed to enter, many of them.
Yes,
that
we
was
had technical
many were
glitches,
waiting.
madam.
So
even I was not able to join continuously.
Yeah,
I was
we had
kept
very
outside.
good number registered and many, I think more than 300 persons had joined. So thank you all the delegates and participants. Thank you so
Everybody
much.
might
Good
have
night.
been benefited with our first day session. So I welcome all to join as well for the second day.
Thank you so
you,
much.
Kavita
So
and
tomorrow,
Meena.
thank you all. Tomorrow we are again going to meet at 4 o'clock. Thank you so much. Good night.